invest in new products and innovations in the medical research field, is sitting at 24% of our total costs, compared to a target of 18%. Capacity development, relatively low at 7%, but increasing to 9%. And then lastly, the corporate and support, our objective is to maintain the total support costs at around about 20% of our total spend, and you can see that we managed to achieve that in that financial year. Moving on to the budget to actual, our actual revenue is slightly ahead of our budget, but very, very close to it, as is our expenditure. And you can see that also on the budget side, we've managed to keep our costs within our budget, giving us a 43 million surplus from a bottom line perspective. Breaking out the variances to budget, you can see that most of the costs and income is very, very much on track with our budget. The only areas that I'd like to draw your attention to is our personnel costs, which are below budget at 403, so keeping those below budget. And then our depreciation, where we actually extended some useful lives of some of our fixed assets, which obviously gave a positive kicker to depreciation charge, and we can see that's 10 million below budget for the year. Next slide. Moving on quickly to the balance sheet, the total assets of the organization increased by 12.4% during the year to 674 million, so a strong growth in our assets. That was mainly driven by the fourth bullet under the assets slide, which is the cash and cash equivalents, which increased by quite a large 20% to 370 million, which is very encouraging as we received injections of funds from our contract funders. And that is, that's a decrease, did I say, in cash and cash equivalents, not an increase. That is decreased by 20% to 370 million. And then if you look at the liability side, very much mirroring that, and in line with the cash and cash equivalents decline, we've shown a decline in deferred income by 33% to 198 million. This results in an increase in our cumulative reserves of 341 million. So this is essentially the reserves that we have in our balance sheet to actually drive investment in research going forward. And we're very happy that National Treasury has approved that we may retain these reserves for the 2021 financial year. Just expanding on the movement in the cash, as I said, that has actually declined by 93 million. Cash received was 1 billion and total cash payments were 1.1 billion, showing a operating cash outflow of 59 million. And then we had further outflows of 33 million, which was the investment in CAPEX as we renovate our buildings across the country, and obviously investments in IT equipment, which explains the movement in cash, decline in cash of 93 million. Then just looking quickly at our funding, you can see that our baseline grant, this is the contribution from National Treasury to the Department of Health. You can see that it has increased below inflation, but still increased up to 2021. Now, the 2021 figure does not include the 150 million received in the last week or two from National Treasury for the emergency funding for the vaccine study. So that blue line in 2021 is actually 150 million rand higher than that. In fact, it probably is at the same level as the 21-22 number, where we have seen an additional 100 million rand adjustment in our baseline grant to actually allow us to invest in other COVID-19 initiatives in the 21-22 financial year. And we're hoping that it's not going to be a one-year injection, and we would hope that would increase over the year in the following financial years, although we've kept it at the current levels at this time. So in summary, just to say that we continue to manage our costs in line with our income, and I think we've shown that in terms of delivering a surplus for the financial year. We have very, very strong reserves in our balance sheet, and we are strongly solvent as we moved into the 21-22 financial year, sorry, the 21 financial year as COVID hit, and I'm very happy to say that our balance sheet was strong as we went into that. And then we've actually continued to invest in our infrastructure, where we invested a further 33 million in improving our buildings and IT. Thank you, Chair. I will hand back to the President. Thank you.
Thank you very much.
Chair. Mongezi, I think this is your section.
Thanks, Prof. Gray, and thanks, Chair. So I'll briefly take you through the human resources slides. Just to indicate that, the MRC, like other organizations, they used to have what is called promotions, but we've since replaced it with a career progression, which looks at much longer term than a promotion, which is a once-off thing. However, I have to state that due to the moratorium, as was communicated to us over the last financial year, we haven't been able to do any career progression and advancement. So, but on a 2019-2020, 60 staff were successful in their applications, of which 88% were Black, 32 and 32 Africans, and 70% of them were females. So this is the one of the avenues that help us to develop a pipeline of scientists. As you would also see later on, it's not the only pipeline, it's not the only mechanism, but also the transformation when Prof. Mphahlele will be presenting on that. So, Chair, you may notice the issues, you may be aware about issues that may happen during the COVID. And similarly, we also had issues in the organization where people were affected by COVID. But fortunately, we've got a system and a program which is called Employee Wellness Program, where our employees could phone the talk call center with any issues that they have. And we've seen that people were phoning on issues related to HIV, chronic disease management, and so on and so forth. This is a confidential talk, and we do not know about that. It's just that to know what issues were discussed, but we wouldn't necessarily know the person. So we also had wellness days just before COVID and lockdown, both in our regions in Cape Town, Pretoria, and Durban, and this program has been very successful, Chair. So in terms of the appointments, these appointments are impacted by the regional targets, and you would see that over the period from 2017-18 to 2019-2020, we have a decrease in terms of Africans that we appointed in the organization, but we are addressing that. Similarly, the other groupings like the colored and Indians are very small percentage, whereas there was an increase in the white grouping in terms of the appointments. Again, due to the agenda inequity in terms of the appointments, we've seen that most of our targets were to appoint males rather than females. So hence you would see that in this slide that more and more males were appointed over the period, particularly during 2018-2019, with a slight decrease in appointments in the males in the period that we are now presenting on 2019-2020. Chair, I have to also point out that we're not proud with the slide, but however, we're making strides in terms of making sure that we've got both racial and gender equity in terms of the appointments. You would notice that from a period of 2017-2018 to 2019-2020, most of our senior staff are the whites, and in this regard, these are the personnel that have been in the organization for a very long period, and most of them are unit directors, but some of them are nearing retirement, and when we replace, we'll be replaced with the designated groups, whether is it African, colors, or Indians, to make sure that we've got a racial equity. Safe to say also that we have started process in terms of step aside, where some of our executive management already stepped aside to make an opening for us to appoint a new executive who would also address the issue in terms of racial inequity, and this person is a white person. So we are addressing this. We replaced the unit directors, similarly the executive management committee members. Again, we also changed how we appoint the unit directors. They used to be appointed for life. Now they are appointed on a term basis of 5 years and which can be extended. Similarly, on the gender, we are struggling a bit in terms of seeing that most of our senior management is males, and you would see that we start trying to move from 2017-2018, we're 54%. Currently, we've decreased to about 51% in the males, which is a move, but we are addressing that. Okay. So what I would like to do now is to hand over to Prof. Mphahlele to present to you the transformation plan for science. Thank you, Chair and honorable members.
Thanks, Dr. Mgode. And good morning, Chair and honorable members. So just to say that the transformation plan for the MRC for the science cohort is focusing both internally and externally. So internally within the intramural domain, because we do have intramural research units, and Mongezi has just spoken to that. And then externally to the universities that are receiving our funds to conduct research. So we would like to influence transformation in terms of the next generation of scientists that we fund, and also the centers of excellence that are hosted by these universities. So internally, we provide an enabling environment that supports research execution. And we also pay attention to gender, disability, and race issues. And as far as disability is concerned, we also aim to develop guidelines pertaining to sick leave, KRAs, and generally accommodating those with disabilities. And if you look at our focus externally, in terms of our next generation of researchers, we have got two baskets of funding. One on the left is scholarships that are funded to students, postgraduate students mainly. And you can see the list there, about 6. And the flagship one is the Bongani Mayosi National Health Scholars Program. Excuse me. And on the right, these are grants which are funded to researchers, starting with those who just obtained their PhDs and moving to mid-career scientists. Next slide. So for the scholarships, we make sure that those who get our funds align their research with the top 10 causes of disease in the country. You can see here that there's been a shift, from infectious diseases to non-communicable diseases, and we also cover research leading to addressing research in injuries, and we also fund, research for maternal and child health. Next. So back to Bongani Mayosi National Health Scholars Program. Just to profile this funding instrument. It was initiated in 2015, and so far we have given awards to 120 students, mainly masters and PhDs, but the majority of beneficiaries are the PhDs. And if you look at 2019, 2020, of the 53 students that were funded, 47 were PhDs. And so far we have graduated 48, and we are very proud to say that of those who graduated, at least 70% are female. Looking again at the demographics of the recipients here, you can see that the majority of the recipients are Black, colored, and Indian, and African, colored, and Indian, and you can see that over the years we have been really funding a majority of Black students. Next. And again, just to emphasize that since the inception of this program, we are very proud to say that female scholars, 78% have been the recipients of these grants. Next. This is just to give you a feel of the breakdown of the research areas that we fund in this program. So you can see that infectious diseases, mainly HIV and TB, account for almost 50%. And then the NCDs, non-communicable diseases, 28%. And obviously the balance is the other diseases, including maternal and child health. And in terms of the recipients, institutions that receive or institutions which train our next generation of scientists, you can see that the majority are mainly the research intensive institutions, UCT, Stellenbosch, and so on. And we also make sure that we get a footprint in historically disadvantaged institutions. So that was about the next generation of scientists. So looking at another portfolio, which is the Centers of Excellence hosted by the universities. We call this extramural research unit. And in the last 5 years, we are proud that we have done a complete overhaul of these programs in terms of growth, leadership, diversity, and portfolio of the research programs. We have established 14 new EMUs, and of the 14, obviously this translated to 26 in total. Of the 26 EMUs that we have, 10 are led by female directors, and 12 are directors from previously disadvantaged backgrounds. Next slide. In terms of the profile of the institutions hosting the EMUs, we have 12 institutions in total, and of the 12, 4 are historically disadvantaged institutions, and you can see by the arrows. Actually, 2 units are hosted by University of Western Cape, 1 each at TUT, University of Fort Hare, and Kaput. Then the profile of the unit directors. I've mentioned that we have made a transformation in the profile of our unit directors, but this gives you a clear picture of how the transformation happened in the last 5 years. If you look at 2016, for example, in terms of directors from previously disadvantaged backgrounds, you can see a steady growth to 2020. And this is quite impressive because out of 26 unit directors, 12 are from previously disadvantaged backgrounds. Next. And then the other funding instrument that we have, and this is very strategic because it is funding both upcoming and young researchers as well as seasoned researchers. In 2013 and 2014, if you look at the profile of the researchers that were funded by self-initiated research grants funding instrument, the majority were whites and very few were colored Indian and African. And if you compare this to where we are in 2019-2020, the situation has changed completely because we make sure that half of the funding pot goes to young and upcoming researchers, and we also make sure that the majority of funding goes to African, Indian, and colored researchers. Next. So the last part that I want to talk to is the transformation in the intramural domain. You have heard from Dr. Julie about the transformation in terms of the senior management and other areas intramurally. But what we have done in the last 4 or 5 years, 2017, we established a program of deputy directors to make sure that if a unit director retires, there is a succession. Even if these deputy directors were not necessarily guaranteed the post, obviously it was just to make sure that we grow our own timber. So in total, 7 unit directors have been appointed since 2017, and I'm glad to say that, in fact, some of these, deputy directors have gone on to become unit directors. Next slide. Next, and this is the profile of the unit directors starting from 2016, and you can see that the second last column, this one, if you can see, the one for the white unit directors, you can see a drop in terms of appointment of white unit directors. And the reason for this is because as we introduce new unit directors, we make sure that we appoint from designated groups. Next slide. This, I think, is the last slide. Just to summarize that intramurally, we do have a lot of other programs to support growth of our researchers, staff development programs. We provide postgraduate study support. We do have our own MRC intramural postdoctoral fellowship programs, and we provide funding and a very competitive funding for intramural researchers, including seed and top-up funding for projects. And we also provide mentoring and coaching. I think this is the last slide. Thank you.
Thank you very much, Professor Gray. Would I assume that's the end of your reporting on your annual plan?
No, sorry, Chair. We're just going to give you the actual indicators, and maybe Mongezi can move through this fast.
Yes, if we can move a bit faster, because we must still also get the second presentation from you, please.
I'll do so, Chair. Thanks very much. So what I will not do is to take you through the Constitution as well as the SDGs, similarly the 10-point plan or the key outcomes. I'll take you just straight to the presentations in terms of our research outputs. So we've got different programs that drive our outputs, which are also linked to the SDGs, as you can see on the slides. And this relates to the programs that Prof. Mphahlele spoke to earlier on. So similarly, this slide, it's exactly the same one: biomedical research, public health, innovation, and so on. And Chair, just to indicate that we had in our previous reporting period 4 strategic goals with the indicators, and I'm happy to indicate that the indicator, which is about governance, we got a clean audit for 2019-2020, and as Mr. Nick Buick, on his finance presentation, we managed to also keep the spend on administration at 19%, which was below the target of 20%. So this slide deals with the publications, our outputs, research outputs. Chair, I'm happy to indicate that for this strategic goal 2, we exceeded the targets that were set, and we've now revised the targets for the new APP, which was just approved by the minister not a long time ago. Then similarly, this is still also strategic goal 2 to indicate that we either met the targets or exceeded the targets. So the third one is the innovation. Mr. Buick mentioned about the amount of money that we spend in innovation. Again, here we've met the target or exceeded the target for both indicators for strategic goal 3. And then strategic goal 4, this is what Prof. Mphahlele has just presented to you in terms of our building our pipeline. You would notice that, Chair and honorable members, we have exceeded the targets that were set for these 2 indicators. Thanks, Chair, and I'll now hand over to Prof. Gray to finish off the presentation.
Mongezi, I think let's just go to let's leave this out, and let's just go to the phase 3B Sisonke study, because this will be available to all the members for their perusal. So if you can just move on to the Sisonke program, I think, just to save time. So I'm going to just present briefly on what the Sisonke open label phase 3B study is, because there has been some confusion. Can you start off with slide 1, Mongezi? You can go to slide 1.
Can you see it?
Yeah, we're on slide 7. Okay, yeah, thanks. So we're just going to explain, the MRC is the sponsor for the Sisonke phase 3 open label study. Can I have the next slide? This study was developed after evaluating the efficacy of the various vaccines. So at this moment in time, we have 4 COVID-19 vaccines, and we only have data on 3 of the vaccines in South Africa against the local variant. And as you can see from the slide, in terms of the J&J or Janssen study, we have a 64% overall vaccine efficacy, and 95% of the cases were from the current circulating variant known as B1351. In the Novavax study, we also have some data which shows a reduction in vaccine efficacy to just under 50% in South Africa, and most of the cases were from the B135 variant as well. So we know the data from that, and we also have data from the AstraZeneca study that showed a 10% vaccine efficacy against the B1351 variant. Can we have the next slide? And so basically, based on this information, when we learned about the vaccine efficacy of the AstraZeneca, we rapidly moved forward using the J&J vaccine because we had just had information that this vaccine was efficacious. We saw that there was high protection in South Africa where the variant was prevalent. We also saw that there was a 72% vaccine efficacy in the US as well. And then overall, as I've mentioned before, 66% vaccine efficacy. And this vaccine efficacy was similar by age, comorbidity, status, sex, race, and ethnicity. If you have a look at this slide just shows you again on a graph various variants and the overall efficacy. And yeah, you can see in South Africa, 82% effective against severe or critical disease in South Africa as compared to other parts of the world. Next slide. So it became a logical transition to use the J&J vaccine. We did this because it was logistically and practically had advantages. When the vaccine is licensed in South Africa, we'll be able to get 5 doses per vial. We don't need any dilution for the vaccine. It can be stored for 3 months in a normal bar fridge, for 2 years at -20. It's easy to scale up, large-scale manufacturing. We expect to have 20 million doses by the end of March, and 100 million doses have been given to the US in the first half of 2021, and the shipping fits into existing supply chain infrastructure and not complicated. If you look at the vaccine efficacy against the various countries, just remember that the vaccine works we get the maximum effect 28 days after vaccination. So until you had your vaccine for 28 days, you may not be protected, and it's important to understand that. But yeah, you see in South Africa, again, just to show you, against severe or critical disease, this vaccine is almost 82% efficacious. Next slide. So based on this data, the National Vaccine Program was stalled or paused on the 9th of February because of the data coming out of the AZ study in South Africa. And we moved rapidly to start the phase 3B open label study to replace the national rollout, and reason why we did this was because healthcare workers are 3 to 4 times more likely to develop COVID. And globally, 1 in 7 cases are in healthcare workers. And to date in South Africa, 40,000 healthcare workers have developed COVID. Just under 6,500 have been hospitalized, and around just over 650 of our colleagues have passed on. And so to transition to the J&J study was almost a no-brainer, because this is a single-dose vaccine and it can protect against severe disease, including South Africa. So just for the people who are on the call, in terms of the vaccine rollout program in South Africa, there are various phases. There's a phase 1, there's a phase 2, and a phase 3. The first phase is aimed at healthcare workers, and there are about 1.25 million healthcare workers in South Africa. The start of the phase 1 was the open label Sisonke study, Phase 2 will be essential workers, people in congregate settings, people over 60, and people who are over 18 with comorbidities. And then obviously the phase 3 will be all people over 18, and the target population there is 22 million. So just looking at the rollout and the Sisonke study, we are the first part of the national rollout, and we're part of the phase 1A, and this is the time of the rollout where at a global level their limited doses are available, and it's a highly constrained, we're in a constrained supply at a global level, and we move forward with the Sisonke. Next slide. So just to show you what is the phase 3 open label study. This is basically you register for healthcare workers, you register on the EVDS. You then get an SMS that invites you for the early access. You have to provide, because this is a phase 3B open study, you have to provide informed consent to take place. Once you've provided the informed consent, you receive your vaccination voucher, you attend your vaccination center for the administration, and basically we will be giving up to 500,000 vaccinations to healthcare workers. We almost hit 200,000 yesterday. We are on 195,000 vaccinations to healthcare workers. We've been getting 80,000 doses roughly every 14 days, and we will get another shipment on Friday, and then we expect to get a big 200,000 doses in about 14 days time to complete the vaccination program. Next slide. So just to summarize, what is a phase 3 open label study? Because I think there's been confusion. A phase 3B open label study is conducted after efficacy of a drug or a vaccine has been established. So we knew at the end of January this year that the J&J single jab study worked after the Ensemble 1 results came available. You conduct a phase 3B open label study before a vaccine is licensed or registered. We started this program before the FDA or any of the European or WHO gave emergency use authorization. At this time, as we speak, many regions in the world have given emergency use authorization now for the J&J vaccine, and it's under a rolling evaluation at SAHPRA in our country. It's important to know this is not experimental. We know this vaccine works. The people don't get a placebo control arm. There's no need for a control arm in an open label study, because what we are testing is the field effectiveness of the vaccine. It's important because it also builds on the safety profile of the vaccine or the drug or the compound, and it basically brings an effective vaccine or drug to populations in an accelerated fashion while registration is ongoing at a global level. But it's also important to know is that these trials are always executed under regulatory and ethical oversight, and so hence we have to have trained pharmacists, we have to have our investigators, we have to have our research sites all at the vaccine sites. You can't just hand over a vaccine. The research team has to work with them. At this moment in time, we're both in both urban and rural sites. We have now 72 sites all over the country, and we have about 32 research centers that are supporting these 72 sites from in the various provinces. And so we work both in the urban and the rural areas, and hopefully we'll be able to conclude this program by the end of April. So I was going to end by saying we need to vaccinate in order to save lives in South Africa. Thanks very much.
Thank you very much, Professor Gray and your team. This was a great presentation. Let me first commend you on your clean audit that you have received. And thank you very much for the two presentations. Members, I have already put out a list, and I'm going to mention the list here again for those who want to raise questions or comments, etc. We have had two presentations. Feel free to speak to both. The list is as following: honorable members, it's Ismail, Munyai, Chirwa, Tseke, Sukacha, Gela, Tembakwayo, Tlengwa, Wilson, and then Dlomo. Honorable Dr. Dlomo has been able to reconnect, so after this round, that's why I've shifted him to last. he will be able to take over the chairpersonship again after this round. In that order, please, honorable members, hopefully I don't have to remind you, if you can, and it's also on the group. Honorable Ismail, you may start, please.
Thank you, Chair, and good morning to everyone. Thank you once again for the presentation. On the initial presentation, let me start with that one first. Firstly, COVID-19 has exposed how quickly, with required focus and resources, a vaccine can actually be developed. How is the Medical Research Council going to use this experience to develop, vaccines for other critical diseases such as HIV, TB, malaria, and others? Secondly, given the economic situation locally and globally, how is the Medical Research Council adapting? What policy decisions have been made to mitigate the impact? Are there any retrenchments planned at the entity, and has the compensation of employees been affected? Fourthly, what is the progress on the HIV vaccine, which commenced in 2016? I think on page 17 of the annual report, there was some, statements on that. I just want some clarity or update on that matter. Fifthly, please provide details on the irregular expenditure identified at the SAMRC and what is being done to prevent irregular expenditure in the future. Has there been any cases of fraud or corruption at the MRC, including any PPE related corruption? If so, please explain. And lastly, on this presentation, please provide the demographics of the master's and PhD students who benefited from the awarding of bursaries and scholarships. And are the conditions of the bursaries and scholarships structured to ensure that graduates go to the public health sector for 2 or 3 years? If not, what are the plans to alter conditions for bursaries and scholarships? Chair, can I just touch quickly on the presentation on the J&J?
Yes.
My first question. Oh, okay, thank you. Has there been any serious adverse reaction to the current J&J trial? If yes, please explain. And has the MRC with the National Department of Health set aside for a possible adverse reaction? Thirdly, has there been any interaction with the IMC in respect to the Johnson & Johnson trial? And if yes, please give us an update and a report on that one. Please, can we be advised when will this J&J trial be concluded? I mean, when will we now be actually be using a concluded vaccine? Because, it's so easy for the masses out there not to understand that we're actually doing a trial now. Everybody just thinks it's a vaccine. But then we also have, health workers that were refusing to take the J&J trial simply because, there are so many questions around it. I just got a few more questions. When it comes to the, to the establishment or, manufacturing of vaccines, should we not now have already started producing our own vaccines? And how far are we in this process? And just two more, Chair, are there any clinical trials on ivermectin in this country? And is the MRC involved in this? I would just like to quickly understand, you've made, some statements with regard to obviously entities that are assisting with data. How are we dealing with this? You have mentioned costs, etc., but how are we dealing with this? Is it on a contractual basis? How are you correlating between all the provinces? Because I know in one province in particular, it was the Orange Rustenburg Clinic Research Institute. I just wanted an understanding of how the MRC is dealing with these institutes. I mean, what does the contract actually contain, Another clarity-seeking question is that how is the J&J trial being handled in the private healthcare sector? Who is actually overseeing it, and what are the challenges, if any? Thank you, Chair.
Thank you. Honorable Munya.
Thank you very much. I think my first question, there was an area, I think, where there was a presentation that seeks to indicate at some stage there was a moratorium employed within the organization, which I think in the presenter that would have really not assisted for the transformation growth and so on. But in final analysis, I'm very excited about the demographics breakdown of the progressions of development of new generation of scientists. That's very exciting, including women and the young people Yeah, that has been very, very helpful in my view. So the other key issues I want to indicate, Chairperson, is that the other key, Chairperson, I need to indicate is that number two, we're very excited about the clean audit that the MRC would have really achieved for the financial year. It's not the first time. They've been doing pretty well on handling finances. With regard to issues of the, data and so on and vaccine, I won't ask that question because I've been asking this question for the almost previous 6 months. So thank you very much.
Thank you, Chairperson. Thank you very much for the presentation. I also have a few questions here. Firstly, I think you've done a very horrible job in ensuring the public is aware that what is currently happening in South Africa is a trial and not an approved vaccine program. And so to this effect, I want to know how you plan on resolving this, on making it overt public information, and not covering it with vaccination program, but just overtly states that this is a trial and it's not an approved vaccination program, because this in and out and jumping in and out of the interchange of the two words has been confusing to your admittance. So I want to know how then do you plan on resolving this particular issue? Secondly, I want to know who's the highest donor or of the SAMRC outside of Treasury. Thirdly, because I had raised this particular issue with SAPRA on adverse effects noted in the Johnson & Johnson trial, they then referred us, the committee, to SAMRC. So can we have a detailed scope of what this looks like throughout the Sisonke trial across the country, and if there are extreme cases or if they have been close to extreme cases, just highlight details to this effect. And number four, I want to know what exactly you mean when you say you hope the phase 1 of the vaccination trial, Sisonke, will be concluded by the end of April. What's the plan? What will stop the plan from happening or from being implemented? I mean, we can't be subjected to the hopes and aspirations of the SAMRC. We want details. We want scientific plans. And if there are things that will stop or thwart the plan from emanating and manifesting, let us know. But we can't, as a committee, be subjected to your hopes and aspirations. We don't want hopes. We want targets. We want numbers. We want dates. And we want challenges to this effect. Wuti, if the plan is to vaccinate 1.25 million healthcare workers, what then changes it to 700,000? What will then prevent the 700,000 from being vaccinated by the end of April? Not hopes. That I don't think you should subject us to hopes, and anyone for that matter. And number five, I want to know what the anticipated timelines are for the 3 phases of the vaccine program, because they also seem to be changing, and like the lack of ensuring that the public is aware of the vaccine trial being a trial and not an actual program. This is also another part that is very vague. We don't have dates anymore, and the dates keep changing. Now there's hopes. So what is the anticipated timeline? What is the plan in relation for timelines on how these 3 phases of the vaccination program will unfold? By the end of 2021, how many people will have been vaccinated? Is the plan still 67% of the population? And because we know that the Minister of Finance, or rather the Minister of Health, has said that not enough money has been made available to this effect, what then is the number by the end of 2021? And number 6, I want to know how much the SAMRC received from the Treasury to do the Johnson & Johnson vaccine trial. And I would also appreciate information on how this process, the details on how the vaccination trial program and in relation to people's comorbidities, if there's any information on that particular part. And number 8, it's back to the race issue. In 2019, you came before this committee, you highlighted the race issue, and 2021, it's still the same issue. How are you addressing the issue of employing a small percentage of Black people? This is unacceptable because it was raised in 2019, and even then you said you are addressing it. 2021, you are still addressing it. How have you addressed it if it hasn't changed? Please give us tangible evidence of how you address the fact that you still employ a small percentage of Black people, and yet in the same breath, you claim that you're addressing it since 2019. It doesn't, to address an issue means to actually work towards correcting an issue, and you're not doing us a favor. So this is a public entity. It's one of the 5 public entities in the National Department of Health. And it cannot be that since 2019, you are still coming us and giving us demographics on the fact that, to admit, in fact, that in a country of 80% Black people and 8% white people, you have 37% Black and 29% white people in the year 2020. This is tragic. What's worse is that this is presented as some sort of victory when it's not. It's regressive. And we want tangible evidence. You are telling us about the step aside program. How many people have stepped aside since 2019 when you came in this portfolio committee? Give us numbers, give us portfolios, give us the positions that they held and who are holding those positions now. Because you can't present to us about a step aside program and yet not let us know who exactly has stepped aside since 2019. So I want to know who exactly has stepped aside since 2019 when you came in this portfolio committee to tell us about the step aside program. And I also want to know how exactly COVID-19 prevented you from making more appointments in your promotion program that you renamed. I forgot what you renamed it to. What exactly about the pandemic prevented this program from happening? Because there's online ways of conducting interviews and all of that. So I want to know how exactly COVID-19 prevented this program from manifesting as per the plan, and please give a detailed and tangible response to this particular question, because day in and day out,
start wrapping up your questions.
Yes, I will. People come into this portfolio committee and tell us about COVID pandemic, but you're not giving us evidence on how this pandemic is preventing you from making promotions. You can't promote people because of a COVID-19 pandemic. Please take us serious and tell us exactly how and why you're not promoting people, Black people, because of COVID-19 pandemic. Thank you very much.
Thank you. Honorable Seke.
Thank you very much, Chairperson. And let me thank the presentation by the South African Medical Research Council, and also appreciate and acknowledge the work that has been done over the years in improving the country's health and providing quality services through innovation and research in our country. And we also further appreciate the institution or the entity for getting the clean audit over the years. I think as members of the committee, we appreciate that, and we are saying continue to do the good work and continue flying the flag of the country very high, not only in South Africa, but globally. Chair, in 2019, the Research Council was celebrating its 50 years of existence. Can the entity share with us on the highlights or activities taken, and what was the impact of these activities? And the other question, Chair, in terms of the entity's communication strategy, how do South Africans perceive and understand the work of the Research Council? Has the visibility of the Research Council improved as compared to the previous years, especially in disadvantaged areas? Chair, on the issue of transformation or gender inequity, as much as the entity have a greater representation of women across the board, but I think a lot still needs to be done, especially in top management, in women representation, especially in top management. The case in point is the number of male presenters who are presenting today. It tells you that a lot still needs to be done. We want to see change. We want to see women represented in the top management of the institution. On the other question, Chair, just want to check how many of your 120 graduates are employed at the public health sector of our country. My last question, Chair, a number of indicators were overachieved at the Research Council, and they indicated that they will set them higher in the next annual report as presented to the ministry. Is the entity not setting targets to stretch the organization to higher levels of performance? Thank you, Chair.
Thank you very much, Chairperson, for the opportunity. Let me also take this opportunity and thank the South African Medical Research Council for a very good presentation. Chair, I've got just 3 questions. The first one is around the personnel cost, which is below budget. I just want to check what are the council doing to address this issue. Then the second one, Chair, is on human resource. The presenter mentioned that there is an employee assistance program. I just want to check, Chair, is this program only for the employees of the Research Council? What about the family members of the employees? And then the last question, Chair, is around the transformation plan for science. I just want to check, Chair, the plan in terms of the disability. How is the council addressing the issue of the disability? And if they are addressing it, can they give us percentages? How far have they managed to address the issue of disabilities? Thank you very much, Chair, and really want to congratulate the council, Research Council, for the clean audit. Thank you very much, Chair.
Thank you very much, Chair, for the opportunity. Let me also join other MPs by welcoming the outcomes audit report. We really welcome the clean audit with no findings. This is a good achievement indeed, I must say, and we are really proud of the good work that the MRC is doing for the country. Chairperson, let me also go straight to my questions. The first one, it's about the presentation that was done by Mr. Mongezi. I just want to check how are you going to address this imbalance in the senior position, because we understand that you have inheritance that problem, but it needs to be corrected. The second one, it's an issue of how has COVID-19 affected the way MRC operates? And the other one, can we also get an update on the test TB research conducted so far? The other one, it's about the last one, Chairperson, my question, it's about if we can get the report, or has there been any spoiled or damaged doses? If yes, please explain. The other questions are covered, have been raised by my colleagues. We are hoping that you will sort it out, whatever challenges that you have, to make sure that you correct the mistake of the past. But we do have a confidence on you, so that at least we move forward in making sure that we serve the country. We really thank you, Dr. Glenn, for the good work that you are doing with your team so far. We really appreciate as a portfolio committee, and we support the report that you have tabled to us today. Thank you very much, Chair.
Thank you, Chairperson. My first question is based on what has been asked about, specifically in connection with the true transformation. But to ask it differently and to say, how possible is it for you to apply the step-aside program that you have mentioned right now to the 29 white top executive as it is, rather than waiting for them to go on retirement? And if you agree, rather than using the step-aside in other ranks, we need it to be applied to the first ranks of the executive, the top executive in the committee. And then to say, if you agree that you'll apply the step-aside program, how soon will it be? Because we definitely want to see a change. We want to see true transformation taking place there. And the second one, during the presentation, the presenter said we rapidly allocate money to fund research of the epidemic in South Africa. My question is that there has been a lot of multiple research conducted in hospitals and some clinics in connection with these vaccines, the vaccines against the COVID-19. But what is worrying is that the recipients, who are the respondents or whatever, the guinea pigs, if I can call them, some of them receive 800 or 1,000 rand, some get money, including some cell phones, because they were given a vaccination. Are you aware of this thing that is happening? And if you are aware of it, how do you control it? Are people supposed to be paid some money for this? And why is it happening? Because these are not health workers, but they are the ordinary South Africans. So to ask you to say, what is your relationship to all these parallel trials that are taking place? And then the last one is, there was on media a recipient of J&J, Johnson & Johnson vaccine in Cape Town, who reported that she experienced headaches, severe muscles pain, and fatigue over the normal 3 days period. And she had to go and consult the doctor and pay from her pocket. My problem is, what is it that is in place for those health workers that experience some severe muscle pains and so on after receiving the vaccination? Is there a clear communication of what is it that they are supposed to do? What is it that who is supposed to help them without them paying their doctors for the experiences of these adverse side effects? Thank you, Chair.
Yeah.
Thank you, Chairperson. Let me greet all the honorable members and the members from MRC. Really, I must say I'm very impressed, because I think the overall performance needs to be congratulated. They have achieved all the performance targets and remain financially strong with the accumulated reserve of 341.5 million. I think you should be specifically note this, and in addition point out that
you should continue to receive clean audit from the Auditor General, and you have received clean audit 7 times. Please keep it up. Thank you. Having said that, I have 2 questions on your presentation. Could the MRS kindly provide more detail on the pipeline they are currently developing to have more specialists and scientists on board? What specific initiatives are undertaking to attract specialist scientists, and what targets have you set out in this regard? Lastly, although one has to compliment the fact that you have achieved all the performance targets, one has to ask whether you will considering setting them higher, and what additional performance targets will you include? Thank you, Chairperson.
Honorable Wilson. Honorable Wilson.
Thank you, Chairperson.
Thank you.
Thank you very much, Chairperson, and thank you to Professor Gray and your team for the presentation today. I think it's pretty much on record that the MRC always does a rather outstanding job, particularly in terms of administration and finance. And I think your continued record of good governance and clean audits is great. It's we don't often see that, and I think your continued levels of excellence must be commended, and I commend all of you, your board and all your senior management. I have a couple of questions, but obviously the bulk of mine are around the vaccinations, Sasonki and what have you. As far as your presentation goes, just on the financial side, on your presentation on your financial side, just a couple of queries there. Your intramural units, you have 7. Are they all still open? Are they all still functional? I think that's quite an important question. And obviously anything that is indicative of irregular expenditure or fruitless and wasteful expenditure is always concerning. If you could just give us an update on how your irregular expenditure arose. But I think the biggest concerns are around vaccine availability. And it was mentioned in the press a couple of weeks ago, Professor Gray, how you had really gone out and bust yourself to try and get access to vaccines for South Africa, and had a degree of success. However, the situation remains. The query first on the 3 months before another vaccine will be registered in South Africa. Could you give us an indication of why it's going to take another 3 months, what the holdups are there, and what the processes are to be followed in terms of that? And I think we can safely say the 3rd wave is on its way. If it's not starting already, just in the last 2 days, I have 3 friends and 2 family members in various areas of South Africa who have tested positive for COVID. It's absolutely alarming. I mean, we haven't been faced with that on a personal basis before. And we're seeing on the daily stats that we're down to just over 500 positive cases a day, and yet the indications are that this is fast changing. And this raises huge concerns about vaccine availability. As of the 22nd of March, we had only vaccinated 182, call it 183 health workers, 183,000 health workers. We've got 1.2 million health workers to get vaccinated, and that's just the health workers. That's before we started on the elderly, those people with comorbidities and all of those kind of things. So having only done 183,000 out of 1.2 million workers is absolutely alarming. And you indicated that there's 3,000 and possibly another 5,000 expected in the next couple of weeks. And that's alarming, because that still doesn't even take us to a third of the amount of people that we need to vaccinate. And that's just the health workers. That's not including the average man on the street, the poor people in the rural areas. And the third wave is here. What is being done to accelerate the system, and what is the holdup? It is the one thing that is on every person's mind. We are inundated with calls about vaccinations and why nothing's happened. I'm inundated with calls of young people in South Africa across the board who are being offered jobs overseas, in various parts of the world. They cannot get work here. There is no work here. They have work offers and contracts for companies overseas, but cannot leave the country and take up these opportunities that they need so desperately because they can't be vaccinated first. And this is an absolute crisis. There must be a way, we cannot deny people opportunities. COVID has done enough damage already. And so many millions have lost their work already. Now we've got opportunities for people who can actually get work, who can't leave the country simply because they can't get vaccinated. And I think that is my biggest concern. I think the situation at this stage is abysmal. I'm not saying that the MRC is entirely to blame. I think the Department of Health in general is to blame for this. But please tell us what is being done to accelerate this. The third wave is on its way. We're going into winter. People are already suddenly testing positive for COVID again. We cannot, under any circumstances, afford another lockdown in this country. It will absolutely destroy a country that is teetering on the edge already. We have people, we have companies, and there was a court ruling in this regard to say that people could order vaccines directly. And we have many companies, very, very big companies in South Africa who are prepared to do that, and yet we don't know who to refer them to. And your assistance in this regard would be greatly appreciated. Thank you.
Thank you very much, members. Before I give to the chairperson, who also wants to raise some questions, and he will continue with the meeting as the chairperson of the meeting, I just want to also raise a few points and then hand to the chairperson. Now, we've noted your two presentations. Thank you very much for those presentations once again. I see that your revenue is up by 3.7% for 2019-2020. And then we also note at the same time that your revenue primarily through your baseline income from the NDOH will be decreased for 2020, 2021, and 2022, 2023, etc. Unfortunately, it's also the time when we have experienced COVID. So your presentation now is an annual report to the point where only 1 month of COVID was part of that period that is being presented. So I do have a concern, and I'm certain you do have some extrapolation that have applied your minds as to how you would be affected in 2020, 2021, and what that would really do to your revenue base. You probably don't have to give figures, but it would be nice to hear if you had been considering where things should be going forward, considering the COVID infection. Then in terms of your expenditure trends, we noticed that you had increased your expenditure trends towards 2017, 2018. There's been an increase, and thereafter there's been a steady line. And what are your current projections in terms of that, and whether you've reached a peak and you think that steady line is because we see that your expenditure is a little bit more than what you had anticipated. So where would you think you'd be getting more funds from? Because COVID surely is here for a number of years, and surely there would be much more work that would have to be done in the near future. Now, in terms of your profile of your unit directors, I have a big concern here and it's been raised by many of the members, the transformation that is slow, and also in terms of your board. And I want to raise specifically, when we talk in the present South Africa, and we were actually hoping that we wouldn't be having that discussion anymore in terms of race. For those of us who fought in the struggle and in the liberation movements. But unfortunately, that is what it is, that we now talk about race, and we mention races, and therefore I have to ask, I see a very small representation by the so-called colored people within your entity, and I'd really like to hear your answer with regards to that. And if we look in terms of the demographics of our country, that surely is also a misrepresentation. And when do you expect to actually get that right in terms of the demographics? Then in terms of your the Sisonke project, we understand it being a phase 3 open label study. We appreciate the fact that this was brought to South Africa, that we could start vaccinating, especially our healthcare workers. We take our hats off and we salute our healthcare workers. And we heard that we've lost about 650 healthcare workers. So in terms of from me, I'm very thankful for the project that has been rolled out. Doesn't matter what we call it, doesn't matter what the name is. The point is that there is vaccination taking place, and that vaccination saves lives, as you said very clearly in your very last PowerPoint slide there. So in terms of your envisaged program going forward.
Sorry, Dr. Yes? Jacobs. May I request Honorable Wilson to switch off her video, please?
Honorable Wilson, thank you. So I'm almost done, Chair. So, and your envisaged program to teach or to reach a population immunity, we see the program is very slow, the rollout of vaccination, and we understand it's also a case of supply and demand, and us receiving the vaccine, etc. But what are the plans going forward to increase the receipt of vaccines so that we can speed up our vaccination program? And very lastly, we've seen that the Sinovac vaccine has been rolled out in some other countries, for example, Brazil, etc., and that the Sinopharm vaccine is at a phase 3 study, and also that the Sputnik V vaccine has been rolled out in some countries, I think the UAE, for example. And if we can maybe get a bit of feedback where we are and where we stand with regards to those vaccines and being able to acquire those vaccines for our country. Thank you very much, Chair. And Chair, you're welcome. Please take over. And thank you very much, honorable members, for the meeting so far.
Okay. Yeah, no, thank you very much for that opportunity also. And thanks for coming in, Dr. Jacobs, to handle the meeting while I was having my challenges of connectivity. It was an IT thing that was beyond my understanding, but someone is coming to assist. I want to join those honorable members who have commended the MRC for their excellent work in terms of governance. Yes, we note and we should really ask them to accelerate their programs of transformation, more demographics, leadership in the space. But we don't often get institutions coming in to present to us with a clean audit for over 5 years. The Department of Health itself is on an unqualified audit, of course, reasonably for a number of years, but they have not been able to move to a clean audit. It really must be something we do mention, and we want to encourage them to accelerate that, because when we do get those who are actually qualified and adverse, those who come in with really worst contribution as disclaimers, we then have to really hammer them. So I would want Professor Gray to find space and time to share your good practices with some of the institutions that we are associated with as to how you really manage to do your work that well. Because if it is that possible for you to have a clean audit, then it might as well be much possible for some others to do the same. Number two, there are slides that you had, but you didn't talk to them about because of time factor. You once came to present to this committee with regards to the impact that alcohol has, and we now know what it did, the absence of alcohol during COVID, that there was a time we did not have alcohol during COVID, and there were certain benefits to the country, in as much as also there was an issue of talk about tobacco. We would think this committee needs to wrap up that discussion with yourself, maybe not today, but maybe find other portfolio committees who are actually going to talk to us regarding some of those issues, because we might be looking at the health part, but there are other committees and other MPs who may be worried about the economic impact of reducing or eliminating the use of some of those processes. So I really wish that we find time to bring back MRC to talk about their research work in terms of those things. The last part for me, it's just a concern and a worry, and I need you to maybe help us to, I don't know whether maybe you also have to release your media statement, because we have had a presentation by the Department of Health on the issues of Johnson & Johnson. And it really was some of the members here who said, at the end of it all, let us get the MRC, in particular Professor Gray, to come and explain some of those issues. In between, we had a team from SAPRA also indicating their contribution and some of their delays on this, that, and the other. Here we have you today, and your very first two slides on the Sisonke trial presentation is saying, based on the efficacy of J&J, this is the route that we have taken. Now, why I'm raising this as a concern was I don't know whether some of us honorable members, we do not share this information wide enough with some of our MPs from our political parties, because as late as yesterday, there's a member of parliament who was saying, yes, we note and I agree, there seems to be a delay in getting our J&J rollout quickly, faster. But that does not open a window for bringing in AstraZeneca, because the member was saying for high-risk members of the society, the elderly, why don't we give them AstraZeneca, because we are delaying in getting J&J. But the figures are showing that that has got 10% efficacy. I mean, if I was in that meeting, I would have just said, why don't we then advocate to give the high-risk members and the Smarties, because we might as well give them Smarties and hope to give them a hope that you are giving them a vaccine. Look, maybe you need to get the delays from the manufacturers, the bigger countries are taking more of that, but will that be a reasonable thinking to then replace or say there's a delay in J&J, therefore let's give our patients Smarties or AstraZeneca and give them that story that you are vaccinated. That was a concern to me, and I would wish that you clarify, because if you just help me to understand and educate me on that part, I then have a responsibility also share with my political party members if they do not understand that part. I don't mean it came from my party, but it came from some members of parliament. Thank you, Honorable Chair. Then maybe, because I was told I'm the last one, we will give an opportunity to the team to reply to the questions that have been asked by honorable members. Thanks, Professor Gray and your team.
Thanks, Honourable Chair, and thank you, honourable members. I'm going to start with the answers, and then I'm going to hand over to the rest of my team to answer some of the other questions. I'll start off with I'll answer all the science questions, and then hopefully some of the funding issues, some of the issues around TB, and we also have Michelle Mulder and Rachel Dukes yeah, that can also answer some of the questions. So in terms of vaccine development, it is clear that South Africa has been involved in early vaccine development, and this vaccine development started many years ago, but was expanded with HIV vaccines, where the South African government and Department of Health funded SAVI, the South African AIDS Vaccine Initiative, and there has been work at an academic level on vaccine development at many of the universities. And the issue, one of the challenges around vaccine development is that you need to go from an academic entity into an ability to scale up and manufacture. And this is where the relationship with BioVac and other vaccine developers are very important. The Medical Research Council has a very close relationship with BioVac, and we are actually working with them on some local COVID vaccine related developments. And one of them is a second generation Ad5 vector that could possibly be a universal boost for all the COVID vaccines that we have. And this, we're working on both a sublingual and oral formulation. And already phase 1 studies have started on the subcutaneous administration, and we'll move to the oral and sublingual later on. So we are working with BioVac as a partner. So we work very closely with them. In terms of other vaccine manufacturing, I'm sure you're aware that Aspen is part of the tech transfer for the J&J vaccine. I think they're one of 7 global manufacturers to do fill and finish, and hopefully they're going to be coming on board to make once they've done their quality assurance and they've been cleared, they'll become manufacturer. They will be producing J&J vaccines locally, both for local use and for global use. So I think just in terms of vaccine development, I think it's critical. The COVID pandemic has shown us that there's an important need for us to develop manufacturing capabilities on the African continent. And the Department of Science and Innovation, together with the Department of Health, have set aside a program, and we have been in talks with DSI and NDOH to also expand our relationship with Serum Institute together with BioVac. So I think that's going on very strong, and that program is led by the DG from Ajay from DSI. So I think that's important that we have to do it. We have to. We have been adapting locally, and we need to work at a global level and be globally competitive. So there is a lot of work happening both at academic centers and with BioVac to try and make us put us prominence in terms of manufacturing. In terms of HIV vaccine development, I'm glad that the honourable member asked that question. So, in fact, tomorrow there'll be an NEJM article where I'm the first author, and we'll be announcing results of one of the HIV vaccine trials that we were involved in. So at this moment in time, there are 3 phase 3 HIV vaccine trials that have been conducted. Last week, the AMP study was published, and this was using a monoclonal antibody with BRCA1, and this showed a proof of concept that a monoclonal antibody can prevent HIV acquisition, and there will be further work on this to look at poly or multivalent monoclonal antibodies, and of that, South Africa has one, CAP256, and that vaccine is being evaluated and will probably be part of a multivalent monoclonal antibody infusions for the prevention of HIV acquisition. So that's a very important and exciting area. The HB10702 vaccine trial that will be announced tomorrow was adapted from the Thai study, and we made it clade C specific. We took the findings of so this is very important. You can't extrapolate results from one part of the world to another part of the world. So in 2007, there was a study in Thailand that showed that this heterologous prime boost using a pox protein prime boost vaccine had 33% efficacy in Thailand. And we were very excited about that project, and we adapted to be clade C specific, which is the clade of HIV that circulates in our country. And we conducted this study, and the HVTN 702 trial did not work. So even you can't translate results from one part of the world and think they're going to work in another part of the world. And I think that'll teach us with COVID-19 as well. Just if something works in one country doesn't mean it'll work in other countries, because there are a lot of other issues. There's different clades that are circulating, different variants, and different force of infection. So we can't infer anything. We have to do local trials to understand whether vaccines work. There's a trial that's ongoing called HVTN 706. This is an Ad26 HIV vaccine. It's based on the same platform that the J&J Ad26 COVID vaccine is developed, and on the same platform as the Ebola vaccine was developed. We go to our DSMB in April, and either we get told we can continue with the trial, which means that the results are still looking good, or they stop them because the HIV vaccine trial hasn't worked. We are busy doing other vaccine trials where we are looking at immunogens to induce neutralizing antibodies. And there's a trial that's ongoing in South Africa that's trying to prevent breast milk transmission, and where we are using an immunogen to induce antibodies to protect babies against HIV, and that's an ongoing study happening in South Africa. The CFO will talk about the irregular expenditure, and Mongezi, you can talk about the lack of fraud or corruption, even with PPE in our organization. In terms of the demographics, I think again, the master students, Jeffrey and Mongezi, can talk about that. In terms of the J&J, the question about side effects, yes, like in Ensemble 1 and on Ensemble 2, around 2% of all vaccinees have had side effects, so this is normal. So the amount of side effects that are coming out of our vaccine, out of Sisonke, are no different to what was seen in Ensemble 1 or Ensemble 2. And these relate to allergies. Sometimes healthcare workers don't want to tell you that they've got allergies. If you have allergies, please work with us so that we can make sure that we have discussions about it. So we have had allergies. We have had people think that they're protected, and so we have had a number of COVID cases who either were infected at the time of vaccination or got infected 3 or 4 days afterwards. We've had other side effects like rigors, as you explained, sore arms, but these are all part of the reactogenicity, and this is what we expect. This is a reactogenic vaccine, and the side effect profile is exactly the same kind of side effect profile we've seen with other vaccines, so nothing different to what we've been seeing all over the place. We have a safety desk. We have a pharmacovigilance, and when all our safety reports go every 2 weeks to SAHPRA, we're mandated by SAHPRA to report on all our safety. So we have an electronic adverse event reporting CRF. We have paper-based adverse event reports. We have a safety desk telephonic contact, and we have, the moment someone gets a vaccine, we also SMS them to remind them if they have any side effects, to let us know. And we also can look at the back end through the NICD and NHLS to look at whether there are any other safety issues that have been flagged. Any hospitalizations, we work closely with the healthcare worker who's been hospitalized and the team treating them to see whether there's any causal relationship between the vaccine and the side effects. So we do expect it. 2% is the same as what we saw in Ensemble. And so we've already vaccinated over around 200,000 people, and you can quickly work out how much side effects we are going to see. So we do expect this is a reactogenic vaccine like all COVID-19 vaccines, and we do expect a robust immune response, which will manifest. We also know that people who have had COVID-19 before will have can have an exaggerated immune response, because obviously they've had exposure. The immune system then recognizes this. It's almost like a prime boost. They've been primed with natural COVID-19 infection, and then we boost them with a vaccine. And so we do expect an exaggerated response. If you've had severe COVID-19, we do expect you to speak to us, and we discuss your vaccination program. And the most important thing is communication. A lot of healthcare workers are desperate to get the vaccine, so sometimes they hide the fact that they've had allergies, or they hide the fact that they've had severe COVID because they are desperate for vaccinations. And so what we do is we do want people to work with us so that we can manage adverse reactions in a way that helps everybody, both the person being vaccinated and the health team around them. At the vaccination sites, which I encourage the whole of the Parliamentary Committee to go and visit, it's important to mention to you, there's a lot of supervision and surveillance. The departments, the DPE, have come to all the vaccination sites. They oversee the program. They monitor us. The South African Health, the staff provide monitoring over us, as well as our ethics committees provide regulatory oversight. It's very important to know is that we're governed. We have to do everything under good clinical practice and under good pharmacy practice. So there has to be good oversight, good vigilance. The informed consent has to be signed so that people know what is going on. In terms of, we're not doing any trials with ivermectin. The MRC hasn't funded any clinical trials with ivermectin. As far as I understand, there's a Section 21 SAPA registration that will oversee some of the clinical evaluations of ivermectin. We are funding antiviral studies that are ongoing, and at the moment these results are available, we will obviously share them. In terms of data sharing, everything is on the electronic vaccine data system, which is an NDOH platform. It's a very good platform, and we are able to share data. We have a data sharing agreement because this is public funding. Data will be in the public domain once all data sharing agreements have been sorted out. In terms of the private sector, we have a 70-30 split. So 70% of the vaccines go to the public sector and 30% go to the private sector. We work very closely with everybody because obviously there are lots of people that are that need to be vaccinated. There are 10,000 GPs that require vaccination. There are 10,000 dentists. There are physiotherapists. There's a whole lot of people that require to be vaccinated. So we work very closely with the private sector. We work very closely with the Department of Health, with the provinces. Every vaccine that we deliver is negotiated by the Department of Health, the provinces, the sites, the hospital sites, and everything. So every vaccine and every allocation is worked through the EVDS, which has become quite strict, so you can't abuse the system. Mongezi will talk about the moratorium, what he meant. The issue around, this is a phase 3B open label study. I don't think we're covering up for anything. We held press conferences. We went on television with the minister. If you go onto our website, if you read the electronic vaccine data system, if you sign the informed consent, everywhere it's very public that this is a phase 3B open label study, and we continue to communicate that all the time. In terms of the Treasury has for the 500,000 healthcare workers, we require doctors, nurses, pharmacists. We have 31 research sites operating in 72 sites at a national level, and Treasury has given us 150 million rand to conduct the study, which translates to just under, I think, 500 or 600 rand a person, which is incredibly cost effective. I think some of the tender processes have come up much higher, even up to 2,000 rand a participant to execute a vaccination. In terms of, I think the extreme cases, a lot of the extreme cases from the vaccine are no different to what we saw in Ensemble 1 and Ensemble 2, and they really relate to issues around allergies, allergic reactions, and they also relate to people who had COVID, long COVID. So we're seeing a lot of reactions for people who've had long COVID or who've had COVID infection. And so we do want to work. So most of the reactions that we are seeing are related to long COVID and allergies in terms of the extreme cases. In terms of we have got up to 500,000 doses from J&J to conduct this phase 3 open label study. You're asking, the vaccines are being, these vaccines are being, when we knew that we could not go ahead with the AstraZeneca rollout, we approached J&J for these vaccines. These vaccines were all over the world. And so they started flying at their cost, the vaccines back to Belgium, to Germany, and there are some in the US. And so these vaccines obviously are flown, and they are then put into a warehouse, and then when there's enough doses, they get sent to South Africa. And so that's why we've got up to 80,000 doses every 14 days, because these vaccines are being collected to be shipped back to South Africa. Okay, and our the last amount of vaccines, which will be 200,000 doses, were in the US. We had to get approval from the FDA. We had to get approval from the US government to allow them to release these vaccines. There's a global shortage of vaccines. 200,000 doses of vaccines coming to South Africa from the US could cause diplomatic issues. And so we had to make sure that everyone understood that this is for the phase 3B open label study, and these vaccines were not taken away from the US citizens. So these things do take time and obviously take a lot of negotiation and a lot of logistical operations. And so the last 200,000 doses will come in about 2 weeks' time, and that will conclude the last amount of doses we get, and those vaccines will be delivered to the sites, and they will be administered, and that will conclude the 500,000 phase 3 open label study that we are having. Obviously, our healthcare workers, there are lots of healthcare workers that have comorbidities. We are watching those comorbidities very carefully. It's very important for us to understand, particularly which comorbidities have more side effects, and also important for us to understand people who are elderly and to understand the side effect profile in elderly healthcare workers. So those are all important with us. In terms of the highlight activities, we did a series of seminars, workshops. We funded a whole lot of academic days. We also did a submission to the SAMJ on the 50 years of academic work that we've done. And so maybe if I left out something, someone else could put into that. In terms of Mongezi, will you talk about the knowledge knowledge translation as a new indicator that we've got to improve our translation of the knowledge that we do? Maybe you can just talk about it and talk about the issues around the indicators. We are very fortunate that we have fine scientists in South Africa and fine health research scientists. And so the MRC is also very fortunate in a lot of the funding that a lot of research that we fund, people are motivated to have it published. And so I think maybe Mongezi, you can talk a little bit about whether we're over or underachieving. In terms of the step aside policy, I think it's important to note that 3 positions at the Executive Management Committee level will be advertised in the next, one is currently being advertised, one will be advertised on over the weekend, another one will be, and another one has just been advertised. So there are 3 other positions at the executive level which addresses the issue of transformation. Michelle Mulder, you'll talk about the tests, the TB issues, the TB tests, and some of the work that we're doing. The step aside, we can talk about that. The issue is a lot of these people are permanently employed and they're nearing retirement. And so these people have, the white senior scientists that have been in our organization have been in the organization for 30 years, 40 years, 50, in some instances 50 years, and they're permanent employment, so we can't exactly fire them. And so what we have done with these people who are nearing retirement is got them to step aside and mentor other people to address the issue of transformation. In terms of the study that was referred to about the cell phone, so this was Ensemble 1. This was the single shot J&J study. It was the phase 3. This was a global study. 43,000 people were enrolled in Latin America, South Africa, and the US. This was an electronic-based program. The only way we could engage in this Ensemble 1, which was important because we know it works in our variant, was that people had to have a platform to enter their side effect profile onto a cell phone. These cell phones could only be used for the app for the electronic data. They could not be used for anything else. There were some people whose grandchildren managed to unplug to hack into the phone and use the data for other things. But the data and the cell phones could only be used in most instances, except for very clever kids, for the Ensemble electronic vaccination record. So we could track in real time side effects. And this was critical for us because we had to do this registration very quickly. The study started enrolling in late October. And by the end of January, we had the results that we could announce. And the only way you can do this is to have real-time data on safety and side effects. And so at the end of the study, the phones are given back and are not for the use of the participants. And as I said before, you can't use these phones for anything else but study-related conditions. Also to emphasize is that both SAPRA and the ethical research committees would have to approve anything to do with reimbursement and things like this. And so everybody was aware that these cell phones were only for the use for, we could only use them unless you had very clever grandchildren. You could only use them for reporting your side effects and your reactogenicity. So I think that's important. In terms of the participant that had headaches, muscle pain, obviously we know that this vaccine is reactogenic. It's like a flu vaccine. We want it to be reactogenic. It means that your immune system is responding and that there will be side effects. So if you do suspect that you are going to have a reactogenicity, we would like to speak to you because you can take Panado before you take the vaccine, which will also reduce the reactogenicity. Again, I would like to say I'd like to invite the parliamentary committee members like the DPE. They've come to the vaccination sites, they've done their audit, they've done their review, they've looked at everything at the cold chain, at the management, at the informed consent processes. They've looked at to see how the participants have been managed, and I think the DPE report you can commission. You can ask them for the Parliamentary Committee on Health can ask for the DPE report. They've always present every vaccine site that we open. They go and they do an in-depth report, and they spend days there to make sure that everything is going as required. In terms of the third wave, yes, I think we're all worried about the third wave, particularly after the April weekend, Easter holidays, and as we're going into winter and as we spend more time indoors, the third wave is imminent. We've seen in our, if you watch our burden of disease, we give out a weekly mortality report. There's a slight uptick, and which we need to keep an eye on, and we need to make sure that we monitor the excess deaths in the country. Just to remind you again, the Sisonke study it vaccinates up to 500,000 healthcare workers, and as the rollout begins, we will work closely with the Department of Health to transition the sites to the rollout vaccines, which will either be J&J or Pfizer. As far as I understand, and I'm not talking on behalf of the Department of Health because obviously this is their purview, but as far as I understand, the J&J agreements have been signed. There's a schedule of vaccines that are available, and I'm sure that we can ask the Department of Health to indicate when these vaccines will come. As far as I know, at a global level, vaccines have been allotted to South Africa, and there should be, as everywhere in the world, in the next 2 months there is shortages, but then afterwards the vaccines are going to flow because the gear up of the global manufacturing will have taken place. And I can from what I can see in terms of the global reports, after in July there will be massive access to vaccines. And obviously, hopefully, and because I can't talk on behalf of the Department of Health, but I think that they will announce the amount of vaccines that are coming into the country in the next couple of months to take us up to July. And so I think we just need to wait and see from them when the receipt of vaccinations will occur. In terms of other vaccines, Sputnik and Sinovac, we know that in Brazil, there's issues with efficacy with Sinovac again, and again points to the need for local data. You can't extrapolate from one country to the next. We have different variants, and so we always need local data. The issue with the Sputnik, which is the Ad26 prime and Ad5 boost, is that it's a first generation Ad5 vector. To remind you that there was a vaccine trial that was executed in South Africa and in the US in the mid 2000s called STEP and Pambili that investigated the Merck Ad5 Gag-Pol-Nef vaccine, and in men, not women, in men who had previous exposure to Ad5 and who were uncircumcised, there was an increased susceptibility. So we to HIV after vaccination. So we had to be careful. With the Sputnik vaccine, we need local data, and we need to be able to see whether the Sputnik, the Ad5 component of Sputnik will affect our HIV pandemic. It's very important to note that. I think important is like why do we get clean audits? I think, Chair, we are scientists, and so we love rules. We love PFMA. Audit is very important. So when you're a scientist, the first part of being a scientist is to be creative. You have a nice hypothesis, and that's the first part of your creativity. But when you execute your experiment, it must be auditable, it must be reproducible, and it must stand up to rigor and scrutiny. And I think that's what makes the MRC makes us good at PFMA. But it's because we understand the importance of reproducibility, scrutiny, and audit. And I think that works, even though sometimes my scientists scream at me and scream at the EMC, the fact that they understand the importance of rules is important for science and for PFMA. The impact of alcohol is very important. We saw the impact of alcohol on motor vehicle accidents, on emergency room violence, and we do definitely note that when there is alcohol control in our country, the emergency rooms are manageable, and the unnatural deaths do go down. And so that's a very important thing. I think going forward, we do need a more robust alcohol regulations. I think we need to increase the age that people can start drinking alcohol. I think it should be 21. I think we should limit the amount of the quantity and the volume that people can buy at a time. And I think we also have to empower tavern owners and bar people to withhold alcohol to people who are clearly inebriated and should not be drinking anymore. So I think those are the kind of things we need to do in terms of alcohol management. We definitely need to regulate alcohol in this country, and we definitely need to get away from selling high volumes of alcohol without discrimination. In terms of you asked the question about the AstraZeneca. Unfortunately, we didn't see any efficacy in mild to moderate disease in South Africa. The vaccine was not evaluated against severe disease, so we can't make a call. So we're in a data-free zone. We have no evidence that the AZ vaccine will work against mild, moderate, or severe disease in South Africa. The only way we can do that is to do the experiment, is to do the study. And if we give out a vaccine where we don't know it works. There's the issue of therapeutic, Chair, there's an issue of therapeutic misconception. If we give a vaccine to someone, we already see it with the J&J study. We have to keep telling healthcare workers, you're only protected 20 days after vaccination. And this is with a vaccine that we know works. But if you don't know if your vaccine works, we worry, Chair, about what's something called therapeutic misconception, that you give someone the vaccine and they believe it works. And then they are exposed and the vaccine doesn't work. And so I think for all the vaccines, whether it's Sputnik, whether it's AZ, or whether it's Sinovac, we do need local evidence that the vaccine works. I've just told you about the HIV vaccine trial. It worked, 33% efficacious in Thailand, and we brought it to South Africa and we optimized it for our own epidemic, and it didn't work. And so that's just a clear example that you can't deduce vaccine efficacy from anywhere in the world. We do need our own local data. So whatever happens, we don't want therapeutic misconception, and we don't want to roll out vaccines where we don't know exactly whether they work or not against our variant. So I think I'm going to stop there. I think I'm going to ask Mongezi and Michelle and Rachel and Jeffrey and our CFO just to talk a little bit about some of the other things that I missed in terms of irregular expenditure, fraud, some of the demographics, some of the transformation issues around scholarships and all of that. So I'm going to stop there and allow someone else to take up what I missed.
If the members that are still to give input will have another 30 minutes between them, so that at least by 12:15, we are almost wrapping up. Thanks.
Thanks, Chair. If I can quickly ask Prof. Rachel to touch on the strategic goal number 5. I think she's on the call. Thanks. Which is research translation.
Sorry. Good morning, everybody. We are trying to stretch staff at the MRC, as was very well suggested by the question from the Honourable Member. And we have added a new target which relates to translation of research into impact on policy and practice. And I think that this is a very important area. We've put it in for the first time in the current APP, and we have set targets that are fairly low, not because we feel this is an area we want people to do little work in, but because it's something that where we have to learn about how easy it is to measure the work that's being done, because of course the target achievement is all audited. But in fact, there is a considerable amount of work that goes on across the MRC in terms of translating research findings into policy and practice, as well as communicating key messages from research in formats where the general public in South Africa can learn and understand more about their health and the society we live in through the findings of research. And so this is an area where I would say to committee members, please watch this space, and we will be reporting more on what we're achieving in that area over coming years. But, you know, a key headline from this year has been, of course, that with all of the research undertaken on COVID and Professor Gray's position on the Ministerial Advisory Committee and the work of the MRC on vaccines, and particularly driving Sisonke, the top line has been that there's been a tremendous amount of impact on policy and practice, and a tremendous amount of visibility of the MRC in the media, communicating findings of research and communicating with the general public around COVID in all sorts of different ways. And in future years, we'll also tell you more when we report with the annual report about the work the MRC has been doing in funding organizations that are taking messages, particularly around COVID and around vaccines, down into community level to generate demand for the vaccine when we are able to actually roll it out across the country at that level. So that's a quick response, but I would say watch this space in future years.
Thanks, Prof. Chooks. Just to add a little bit on that same program on research translation, we are also collaborating with Open Society Foundation in the United States, where we have funding that we're also leveraging in terms of addressing vaccine hesitancy, which South African Medical Research Council, together with African Union as well as CDC, we've developed a framework for the fair allocation of vaccine across the continent. You may have seen, as Prof. Glenda Gray indicated, that most of the Western countries bought a lot of vaccine, which is referred to as vaccine nationalism. Hence, countries such as Canada, I think there was indication that they bought vaccine that they could vaccinate their population 2 or 3 times. So, the indication from Prof. Gray around vaccines that have been collected around the world, this could have been as a result of instances such as vaccine nationalism. So there was a question around the fraud and corruption, including the PPE. So the MLC, we also utilize PPEs for our clinical trials. So we procure PPEs utilizing the transversal contracts that has been arranged by National Treasury. To my knowledge, there hasn't been any corruption related to that. So we even received a donation of vaccine of PPEs from Fred Hutch, which is in the United States, to allocate to our researchers. As you know, our researchers are also susceptible to COVID-19, particularly those in the clinical trials. So to my knowledge, I do not know anything relating to PPE. We last week had an engagement with the Auditor General just to get understanding of the Sisonke, and they will be auditing the Sisonke open label study. So we will give feedback. Obviously, it will be in our annual report once the Auditor General is done with that. There was a question around the moratorium. So the moratorium wasn't related, it was only relating to the career progression, and that's not the moratorium that's been set by the MRC. It's a moratorium that was set by National Treasury together with a communication from the National Department of Health, and which is similar to what's happening with the agreement that government had with the organized labor, the unions, that there were no salary increases. So in that moratorium, there's an indication that there shouldn't be any changes in the conditions of service for any staff, including the remuneration of board members. And in this regard, we implemented that moratorium as an instruction from the executive authority, so which affected also career progression and advancement or promotion as it commonly been known. I think Prof. Gray indicated on the senior management, when I did a presentation, I did indicate that we're not happy with what we have. And Prof. Gray indicated the issue that this is a historic effect that we couldn't fire people. However, we are addressing this issue. And I understand from Honorable Member Chiwa, she indicated that we did come up with this in 2019. But again, we have a labor issue if we were to fire a person just to address the demographics issues. However, I think we take the point, and this is what we will also discuss with our board to see how we can fast track this process. So there was a question around the personnel costs, which I'll ask Mr. Nick Buick to deal with that, including the issue on irregular expenditure for the 2019-20, which we had about 5,632, but the closing period, the closing balance for that was 0. So if I can ask Mr. Buick to address the issue on irregular and fruitless expenditure, as well as the personnel costs. Thanks.
Thank you. And if you allow me, I'll deal with the other financial questions. If that's okay, Mongezi?
That's fine.
Yeah. Just on the irregular expenditure and fruitless and wasteful expenditure, we did on page, I think it's 200 or so on the annual report, our regular expenditure was 5,632 Rand for the year, and our fruitless and wasteful expenditure was 873 Rand. Obviously, we're encouraged that it is declining, and to my knowledge, we haven't had any so far this in the current financial year, at least on the irregular expenditure front. But obviously, even 1 Rand of irregular expenditure is too much. So we have a number of initiatives in place to curtail it. We have training programs, and we also have what we call our SEM forum, which runs monthly, where we get we actually stress the issues and take them through the policies with regard to SEM, and also I think permeating right from the board down through the executive committee. We have a zero tolerance approach to irregular and fruitless expenditure, as well as a rigorous consequence management program in place, which I think has contributed to the decline, but obviously you can't take your eye off the ball there. Then there were some questions on the which is the highest non-treasury funder outside of National Treasury, and that currently in the last financial year was a DSI, Department of Science and Innovation, with 128 million Rand, which was funded, and then various US agencies such as CDC and the NIH following that. The question on the personnel budget and why are we below budget? If you look at the actual costs, you can see that the actual compared to last year went up by 8.8%. And I did explain why that was the case. However, it was still below budget. And I think one needs to look at the mix of research expenditure between laboratory costs and staff costs as to the type of research that we do. And I think our budget was probably on the contract side a little bit optimistic with regard to the number of staff that we will be employing on projects. Then there was a question around the budget for the Sisonke. There is a slide in the presentation on the budget and how much was being funded by national government. As Professor Gray has indicated, we have received 134 million Rand after accounting for VAT from National Treasury. Then there was a question on terms of how we weathered the storm with regard to COVID in the current financial year, and what is the financial impact of COVID, and in terms of our baseline funding, etc. Obviously, we haven't closed the books yet on the 2021 financial year, but they will be closed shortly. And the situation really is that we've seen a decline in our research activity on our traditional research, and our costs have actually shown a decline there. One example would be travel. As you can imagine, nobody's traveling a lot, and we've seen a significant cost reduction there. But what we have seen is obviously a marked ramping up in terms of funding for COVID research. We've managed to ring fence 80 million Rand of our own money, and we've had various other funders such as Solidarity Fund and others, which means that we've rapidly redirected 260 million Rand to COVID funding in the current financial year. So we have been quite responsive to that. And I think together with our strong balance sheet as we moved into the financial year, we have withstood this remarkably well financially. I think that's basically it in terms of the financial questions. Thank you.
Thanks. I'll ask Prof. Mphahlele to address the issue on the number of graduates as well as the detail on the pipeline being developed of scientists. Thanks.
Yeah, thank you. Thank you very much. So there were questions related to more demographics on recipients of our scholarships, and also a question on employability of the recipients of our scholarships. So I will try and combine these two questions. And I must say that even though I just singled out the Bongani Mayosi National Health Scholars Program in my presentation, I did indicate that we have got quite a number of scholarship programs. We have got Clinician Research and Development Scholarship. We have got the National Medical Scholars Program. We have got Internship Scholarship Program and others. And if you look at the demographics of the recipients, what we have presented for Bongani Mayosi and HSP is not different from what you see in other programs. Obviously, I haven't presented it, but just to give you a feel, if we look at, say, Clinician Researcher Program, we have got in total 35% of recipients are white, and 23% Indian, 10% colored, and 33% are African. And the trend is the same in all other programs. We are giving more scholarships to generally Black students. So that's the case, and in terms of the employability of the recipients of our scholarships, MRC is fortunate in the sense that most of the people that we fund in our scholarships programs, they are clinicians. These are medical. These are people with medical degrees, and they want to become researchers. So it's not like they will not be employed. They are already employed. We also have programs where we are able to fund people to leave their daily jobs and focus on research for 4 to 5 years. And after they obtain the PhD, they go back to their own job. And a number of other programs, because we pay more emphasis to the PhDs. A number of people who take up the PhD scholarships, these are the people who are already very keen on research, and after getting their PhDs, they go on to do research. So you can be rest assured that number of our recipients of our scholarship, they are definitely employed. And then the last part that I can touch on was on the support that we give to staff with disabilities. Clearly, there are a number of things that we are doing as an organization. We are running workshops to encourage staff to declare the disability. As you know that some of people do not like to declare this. So we try and encourage people to declare, especially the new staff, so that we can deal with it. And we then accommodate them depending on the nature of disability. So we can provide, supportive work environment depending on the nature of the disability. We can make sure that the KRAs that we develop in consultation with the staff, they are able to be addressed by the staff with disabilities. I mentioned something about sick leave, that if they do need sick leave or special sick leave, we make sure that we cater for that. And a number of other things that they are just dedicated for staff with disabilities. And then the last point, we have taken note about the profile of the UDs, especially the colored UDs. And when you address transformation issues, it's always a work in progress. It's not, we are not at a stage where everything is perfect, but we are constantly addressing these issues. Thank you very much.
Thanks, Prof. Mphatlele. So there was a question around the communication, the MRC and its perception in terms of the disadvantaged communities. As I've indicated that, with the Open Society funding, We will be going to the communities. We engaging partners such as the Treatment Action Campaign and Africa Alliance. But maybe I can ask Dr. Alfred Tutla just to give us a bit of an indication of the program that we're doing in Worcester in terms of a center of TB on Stop TB. Dr. Tutla.
Thank you, Dr. Mongezi, and thank you, members. Yeah, so in terms of the program on TB, that I do not have specific details about. What I do know is that we did actually do a TB communication program that we actually went into Worcester. That was in 2019. That we basically had school kids come to an exhibition where they were actually taught about TB as a disease, how you basically can get TB, prevention methods, and there were various videos that were actually shown to the students, so it was very experiential. What I can actually add on to the research translation aspects of the SMRC and the work that we're actually doing that Dr. Mongezi talked about and Professor Rachel Dukes talked about in terms of Goal 5 in our APP, is that we're working with the National Department of Health to work on COVID-19 vaccine hesitancy and misinformation. And on that, what we've done is that we've developed a communication strategy that we've worked on with the Department of Health and the Department of Science and Innovation. And that strategy has actually been shared with the Solidarity Fund, and we're looking to have that program actually funded. And we're going to actually roll that out as the SMRC, the African Alliance, which works very much in communities. And yeah, once that funding is actually allocated, we'll be able to roll out this program. Thank you very much.
Thanks, Dr. Tutla. Just to touch on briefly, I know, Chair, you gave us until 15:15. So we formed no strategy regarding the stopping appointments in terms of COVID. We had a couple of appointments during the COVID. That was a question from Honorable Chirwa. And I've addressed also the question around the promotions or the career progression. The other one was the employee wellness program, whether is it only for the employees? No, it also involves direct family members. They can also phone the call center. I think Prof. Mbatlele has just touched on the issue around the disabilities. In our annual report, you would see in page 189, we've got 6 people that we declared the disability that we could only put in the annual report. However, as Prof. Mphahlele has indicated, that we are encouraging people to declare their disabilities. And again, there's a bit of a misconception that people think that the disability is only the visible one, where one would be limping or something to that effect, but it goes a little bit further than that. So I guess we just need to educate people more to to the issues around the declaration of the disability. Just before I hand over to Prof. Gray, there was Honorable Dr. Dlomo say, why don't we share these experiences that we have in terms of good governance? And we've done that. We've assisted the establishment of SAPRA. As you know, SAPRA used to be MCC. So we've helped SAPRA quite a lot to put lots of things in place, like appointments of the HR executive. Some of the procurement issues, we were assisting them in terms of creating transversal contracts for them. So, Honorable Dlomo, we've been assisting our sister organizations in terms of good governance. Thank you very much. Let me hand over to Prof. Gray and Prof. Mahlangu for the final remarks. Thanks.
Prof. Mahlangu, I just think that Michelle, do you want to say anything about our funders? I think there was a question about who is our biggest funder. So, our co-funders, I would think just at a global level, our biggest collaborators or co-funders are the Newton Fund, which is the UK MRC, and the NIH are our 2 big US NIH. So these are 2 government entities are our two biggest funders. We do get some funding from the Dell Foundation, the Elmer Foundation, and the Gates Foundation. And I think, Michelle, you wanted to just talk a little bit about TB. There was a question about the TB innovations. If we've got time, or must we end?
That would be grateful if you talk about TB, because we are about to get a TB presentation right now, and today is a TB Day internationally. Speak about it, thanks.
Thanks, Professor Gray, and good afternoon, honourable members. So just quickly, just to touch on the funding. Again, the one thing that's happened with COVID is we've had a number of non-traditional funders coming in. So certainly in this last financial year, we've, for the first time, obviously received funding from Solidarity Fund, and we're starting to see funders like Elmer Foundation, Michael and Susan Dell Foundation, and others, really with a strong interest in supporting these areas. So just to add that to what Prof. Gray was saying. In terms of TB, we're funding a number of innovations in the TB space. We have been just supporting a TB drug discovery program for a number of years now at University of Cape Town's H3D facility. And this is co-funded with the Gates Foundation. It's now become part of the Global TB Drug Accelerator. And in fact, one of the platform technologies which we're funding at UCT Medical School is on screening for biological activity against TB. And these assays are now used internationally by the TB Drug Accelerator. We also have some projects in the TB diagnostic space looking at non-sputum-based diagnostics for TB. And we have a project that has identified 7 urinary biomarkers, which are now being used, developed into a points of care test. And then linked to that, we also have a project where they have identified a number of markers that provide correlates of risk of TB disease treatment success and risk of recurrent TB. And these are now being validated and also developed into points of care assays. So we continue to find new ways or to fund the discovery of new diagnostics and particularly points of care to extend the kind of screening and diagnosis that can be undertaken for TB.
Professor Gray, your last words.
Just thank you very much. Maybe and Prof. Mashnanga, I don't know if you want to say something, but just Chair and honourable members, thank you very much for your scrutiny. We really appreciate this interrogation because it's important for us as a public entity to be responsive and understand the concerns of parliamentarians. So we do appreciate this, and we hope that we've answered your questions and that that you would use us as a resource. The MRC is a spectacular organization. It's very responsive, and I'm very proud of the work that we do. Chair Mashlanga, I don't know if you want to say anything, Johnny.
Through you, Chair, I just want to echo the same words. It remains for me to thank all of the members, honorable members of the Portfolio Committee for this very, very productive interface. We remain at your disposal, of course, in getting the necessary data that you require to be able to formulate policies. And we're looking forward to the next interface. Hopefully, we'll be able to address most of the questions that have not been addressed today. Thanks very much, Chair. And I would like to thank members of the MRC board, the executive committee and staff for availing themselves to this meeting.
Thank you very much to the board chair and all the board members. Thanks to Professor Gray too and the team that came with her. We are grateful about the interaction. We will continue interacting with you. Yes, there has been an expression of our pride in you because of the good work that you continue to do. But members were also not shy to point out some of the challenges that you still face and hope that you'll continue working on them. We would like to then release you now because it has been a long morning with you. and we really enjoyed your contribution. We have another presentation from the TB team. Thanks.
Thanks, Chair. Bye-bye.
Thank you. Thank you.
Bye.
Thank you. Bye.
Honorable members, we will take that you can stretch yourself around where you are as we are introducing and welcoming the next presentation that comes in from, I think it will be either Tsotseka or Smusiso. They will introduce themselves. But just to prepare, today, the 24th of March, is a World TB Day. There are countries in the world that worry about TB. South Africa should be one of those countries, because for as long as we can remember, TB has been a problem of this country, maybe since we started having mines. And there's a saying that if there's TB in SADC, and you look at TB as a snake, the head of that snake is in South Africa. Unless and until you deal with the head of the TB in South Africa, it doesn't matter what you do in Swaziland, Lesotho, Botswana, and Zimbabwe, you have not dealt with TB in SADC. So it probably calls on us, honorable members, that this government, ourselves as MPs, should be doing much more on TB awareness and TB leadership, championing it, because it is actually at our doorstep. We would therefore want to welcome the presenters and indicate to honorable members that it's just about a day or two before we face 365 days on COVID. It was close to that day to launch a TB caucus in Parliament. We did not manage to do it, and maybe have a debate about it, what is it, and all that. So they come back again to present to us, and I hope that you'll be able to listen to the presentation and maybe create a program for us, because parliamentarians in there are looking at us as members of the portfolio committee who should lead and talk about TB better and much more often than them. I now bring this to the members who are going to present this program to us, and hopefully members will be able to engage and will listen to your advice. Members, what do we do with this pandemic? Over to you, members who are presenting.
Thank you very much, Honorable Chair, and good morning, afternoon to the honorable members of the Portfolio Committee on Health. My name is Tsotseka Nogoduka. I'm the Executive Manager for the National Strategic Plan implementation at the South African National AIDS Council, SANAC. And today I'm here with Matsidiso Sopodi, who is the lead for TB program at SANAC, and Mr. Sibusiso Hlachwago, who is the TB Caucus Secretariat placed at the South African National AIDS Council in Pretoria. So the chair has indicated we'll just take quickly the members of the Portfolio Committee today on the TB Caucus, what it is, and what we need to do as the members of the Portfolio Committee to take forward the agenda of the TB Caucus. My slides. In terms of the coordination of the HIV, TB, and STIs response in South Africa, we are guided by the National Strategic Plan, the NSP 2017 to 2022, which is a roadmap that has given us the multi-sectoral response for HIV, TB, and STIs in the country. And we've made progress, especially in the past 10 years, but we still have challenges lying ahead of us in making sure that we reduce new infections, especially for HIV and TB. We are able to still close the gaps in realizing the benefits of treatment as prevention, as well as implementing progressive policies for TB and HIV in South Africa. So we still have a long way to go, but the NSP is here. It has 8 goals, with goal 1 being prevention for HIV, TB, and STIs. Goal 2 is focusing on treatment. Goal 3 is reaching all key and vulnerable populations with the services that they need. Goal 4 is talking about how we address social, economic, and cultural factors that fuel HIV, TB, and STIs. And Goal 5 is referring us to grounding the HIV, TB, and STIs programs around human rights principles. Goal 6 is talking about promoting leadership and accountability at all levels for delivering the NSP. Goal 7 is mobilizing resources to support achievements of the NSP targets and attain HIV, TB, and STI programming for the country. And Goal 8 is talking about strengthening and gathering the use of information for us to be able to monitor the implementation of the NSP and track successes. Just quickly, Chair, if we look at the NSP, there are key TB activities that the NSP needs to achieve. There's specific goals relating to TB prevention and treatment. There's the research and development that we need to achieve as a country for us to be able to respond to our TB pandemic. TB care cascade, where we are looking at 90 people that 90% of the population should be screened for TB. And 90% of those screened that require treatment should be initiated on treatment, and 90% of those that are on TB treatment should be successfully cured by the end of the TB treatment timeline. We have done the TB investment case, where we are looking at what are the key critical interventions as a country.
We can't see the slides as they are presented, if ever there are slides, please. Chair?
Chair, I can see the slides.
The slides are clearly visible, clearly.
Okay, on my side, they are not. That's why I was asking.
And I also don't see them.
I have Richard again, members. Are you able to see them now?
No.
How many members cannot see? Honorable Wilson and myself said they can. How many others are having a challenge?
I don't have a challenge on my side. I can see the presentation on the screen, Chair.
Because I don't know whether it's a local or a national program. It may as well be. Because if it comes to me, Gela, Wilson, someone else, then there must be a challenge locally where we might be having a member sitting where he's sitting. Honorable Sokacha and Honorable Dr. Kembegwa. Any other member who can't see?
I'm fine now, I can see now.
Yeah, just try and press a button there. That will, I don't know what happens, but
may I continue, Chair?
Continue, Mr. Chair.
Thank you, Chair. So in the NSP, focusing on TB, we've got key populations specifically for the TB response in the country. The Parliament Caucus on TB is also in the NSP, as well as the civil society response around responding to TB in South Africa. Just to look quickly, Chair, on the United Nations high-level meeting that was held in 2018, looking at the targets and progress, how far as South Africa have we reached? If you look at the table that I've shared, there's 6 indicators that we needed to reach for us to make progress. Out of the 6 indicators, 4 indicators we have not met the target, and 1 indicator we are not even collecting as a country. So we've only managed to meet 1 indicator, which is preventative therapy in people living with HIV in South Africa. All the other indicators we have not met. If we're looking at nationally, looking at our TB treatment cascade based on the recently published TB survey in South Africa, we are having our cascade leaking and missing patients across as we implement the TB program. In terms of the TB incidence, there's supposedly 390,000 people infected with TB in South Africa. That is what the survey told us. But if we look at those people in terms of the ones that have been tested in the country by our TB program, we've managed to test 335,000 people, missing about 54,000 people. Of those that have been tested, we diagnosed with TB 311,000. And of those that we have been diagnosed with TB, only 235,000 were notified and started on treatment. Out of the 235,000, only 186,000 were treated successfully for TB. So if you compare at what projections we have, that we have got 390,000 people that are supposedly living with TB in the country, and in a year we managed to only treat 186,000 of that 390,000, we can see that our TB program is not doing well. So there's much work that we still need to do as a country to address TB. In terms of the districts that are highly burdened with TB in the country, all our districts in the country have high TB in terms of the statistics, but these are the districts that have highest TB incidence in the country. In Gauteng, we've got 3 districts: the city of Johannesburg, Ekurhuleni, city of Tshwane, and West Rand. That is 4 districts. KZN, we've got eThekwini. In Mpumalanga, we've got eHlanzeni. In the Eastern Cape, we also have 4 districts: the OR Tambo, Nelson Mandela Metro, that is Gqeberha, Chris Hani, Buffalo City, and South Cape Batman. In Free State, it's the Mangaung Metro and the Lijolo Puzo. In Northwest, Bujanala and Dr. Kaunda. Limpopo, the Greater Sekhukhune and Waterberg. And in the Western Cape is the city of Cape Town and West Coast. So in eThekwini and the city of Johannesburg, these are the districts that have the highest TB in the country, and they have reduced only 25% in terms of their notified cases if we compare 2020 and 2019. So what we are seeing is that there is a bit of decrease in the TB incidence in the country, but the reduction of the new infections is not at a fast enough pace for us to see that we are going to be meeting our 2030 targets as the country. So why are we talking about TB Caucus today? As I've indicated in Goal 6 of the NSP, it talks about promoting leadership and sharing accountability in our response for HIV. So TB Caucus falls under Goal 6. And what is the TB Caucus? It's a unique network of political representatives. It's apolitical, so all political parties that are sitting in Parliament should be members of the TB Caucus. The TB Caucus members play a crucial role in holding governments into account and ensuring that the commitments that are delivered around TB are delivered and that TB epidemic can be eliminated. The members of the caucus have to work collectively and individually to increase progress against the TB epidemic at all levels in the country and contribute at a regional level and at a global level. The TB caucus will be supported by SANAC for Secretariat support, and at the provincial level, it's supported by the Provincial Councils on AIDS as Secretariats. So for the members of Parliament to be able to be members of the TB caucus, there are principles that are outlined in the Barcelona Declaration. This is the declaration and a founding document for the TB caucus, where members will be agreeing to work across geographical and political divides in a non-partisan and inclusive fashion, where members will be agreeing to engage with civil society and all other stakeholders involved in the fight against TB, and where members will be agreeing to support activities that will be confronting stigma and social isolation associated with the disease. So the TB caucus is a global movement. It is also available at regional level. And today we are presenting at a national level so that we can have a national structure, and provinces are also the provincial legislatures working on establishing TB caucuses. And the TB caucus in South Africa will have an advocacy agenda where members will be able to advocate for TB financing so that we have enough resources to respond to TB. innovative prevention and treatment approaches are supported, facilitating and advocating for integration of TB and HIV, leading human rights agenda around TB, as well as ensuring that we've got enough resources, especially human resources for health, for us to respond to our TB challenge in the country. Members of the TB Caucus will be engaging with their communities and constituencies around TB, ensuring that there is a built high-level political commitment by the members to drive the TB agenda in the country, and there'll be a stronger voice and a louder voice that is legislating for TB response in the country, advocate for multi-sectoral approach, ensuring that all relevant stakeholders, especially government departments that are supposed to respond to TB, are responding to TB, and it's not only the Department of Health that has a responsibility to respond to TB. Ensure and facilitate patient empowerment through engaging with communities and constituencies, as well as make sure that we're able to draw lessons from the HIV community to be able to respond to TB as a country. In terms of just a quick background on where this TB Caucus comes from, in 2014, the UK Member of Parliament, the Honourable Nick Herbert, with the former South African Minister of Health, Dr. Aaron Motsoaledi, co-founded the Global TB Caucus at the first Global TB Summit that took place in 2014. In South Africa in May 2018, as a lead up to preparing for the UNHLM meeting that took place at the United Nations on TB, South Africa requested TB HIV Care as an organization to support the launch of the South African TB Caucus. So in 2018, September, the first TB Caucus was launched in South Africa, and the debate in Parliament took place. There was a resolution that was taken in Parliament on 12th of September that the chair of the Portfolio Committee on Health and the chair of the Social Services Select Committee would act as co-chairs of the South African TB Caucus. It was also discussed in Parliament that there will be a coordinating body of the South African TB Caucus, and it will consist of 11 members from the National Assembly and 9 members from the NCOP. And these will be the members that will be driving the agenda around the South African TB Caucus. That was in the 5th administration of government. And then on the 6th administration of government, we had the South African National AIDS Council Interministerial Committee that was held on the 23rd of August in 2019. In this meeting, it was then resolved that the South African TB Caucus should be institutionalized as a SANAC program. So we no longer have an organization, TB HIV Care, leading the work around TB Caucus. SANAC is now leading the work around TB Caucus. And the SANAC was then required to establish the South African TB Caucus Secretariat. Currently, it's sitting within the SANAC Trust, and it's already established. We were supposed to launch the South African TB Caucus on the 15th of March 2020, and at least by the 15th of March, we should have launched 3 provincial TB caucuses. Unfortunately, Chair, as you are aware, that COVID found us, and we were unable to continue with the work around the TB Caucus. So hence we are presenting today. The relaunch of the TB Caucus has not taken place at a national level. During the COVID-19 response as a country, we continued working and supporting to ensure that the TB Caucus activities were taking place. We had opinion editorials published in Bekisisa, where the Honorable Chair of the Portfolio Committee, Honorable Dr. Dlomo, in March 2020, as build up to World TB Day, had commented around how do we ensure that we continue to deliver TB services whilst the country was responding to COVID-19. We also had other opinion ads that we published on behalf of the leader of civil society, Comrade Steve Letsike, as well as the MEC of Health in the Northwest Province, Honorable Sambata. We also had hosted an international webinar where we looked at TB political advocacy, sustaining TB services during COVID-19 pandemic. In this webinar, we had Dr. Zweli Mkhize, the Minister of Health. We had Lord Nick Cabot, we had Dr. Eric Busby, we had Comrade Steve Letsike, and we had Honorable Lizinkosi, the Minister of Health in Eswatini. Unfortunately, at the last minute, the chairperson of the Portfolio Committee for Health, Dr. Dlomo, was required to take on another assignment, and he could then not participate in this webinar, but the webinar did take place. Also, Chair, just to report that the Northwest Provincial Legislature held a debate and launched their TB Caucus in March 2021. So they've recently launched their TB Caucus. And it's the only province to date that has launched. So, Chair, today we are coming here to propose the next steps for the Portfolio Committee, that the Portfolio Committee agrees that the debate at National Parliament takes place, where the Minister of Health can lead this debate and present on the status of TB in South Africa. We also need to brief the Speakers Forum on the TB Caucus so that the provincial speakers can be able to drive this agenda at a provincial level. We need to launch the TB Caucus at National Parliament and members of Parliament to sign the South African version of the Barcelona Declaration, which is the founding document that commits members on key activities that they need to take. And these members will also be inducted on the work of the TB Caucus. We will continue to work with the members to ensure ongoing awareness and messaging around the TB in the country, as well as arrange at a later stage for an engagement that will involve members of Parliament and representatives and leadership of the SANAC civil society, so that we can have a joint program in addressing TB in South Africa. Thank you very much, Chair. Back to you.
Honourable members, I have already received requests from members to engage. I'm sorry, Honourable Ismail, I made you number one. Above you, there was a hand from Honourable Kela. So Honourable Kela will be number one, number two, Honourable Ismail, three, Honourable Chirwa, and number four, Honourable Sokacha. Those are the ones I have received so far. If there are any other members who would like to engage, please indicate. Honourable Kela, start.
Thank you very much, Chairperson. Let me welcome the presentation from Sister Ceka. My first question, Chairperson, it's around the responsibility of members of Parliament. What is our role in this TB Caucus? If maybe we can get more clarity on that one. The second one, Chairperson, it's about that we welcome actually their proposed next step for the debate, TB debate at the National Parliament. And also we are looking forward to work with them. The other issue, Chairperson, it's around the issue of the provinces, Chairperson. I'm happy that at least there's one province that has already launched the TB Caucus, and also other provinces will also do the same. And also the other issue that I want to check with them, Sister Ceka, is the issue of that province. They do have a provincial AIDS council and also district AIDS council and local AIDS council, where also TB issues are also discussed. But maybe you are coming with something different, or maybe if we can have that integrated or relationship, or have one thing, but I need a clarity on that one, because also it's already there. The other issue, Chairperson, it's an issue of To whom does the country TB caucus account to? And the other issue, it's the issue of funds. Do you get any donations so that at least we know as a members of the portfolio, but also will welcome the issue of that the chairperson of the portfolio committee be involved in this TB caucus. That will be my take, chairperson. And we need also to close the gaps in terms of making sure that as political leadership, we are at a forefront, because really TB is also a pandemic that is very serious and it's killing. So we need to make sure that on awareness campaign, as politicians together with Abosisixoxeka, we work as a team to make respond and also to make our people to be aware about TB. Thank you very much, Chairperson.
TB team, don't feel that we are not asking too many questions. Some of the slides are clear, but other members are experiencing connectivity problems where they are now. I am getting those messages. So there's going to be 4 other members asking you questions. Next is Honorable Ismail, Honorable Chirwa, Honorable Sokacha, and then myself.
Thank you, Chair. And once again, thank you for the presentation. I just have some clarity-seeking questions. Number one,
come closer to the mic, Honorable Ismail.
Thank you, will do. Please advise who sets the agenda for the country TB caucus and how often should it meet with the relevant stakeholders and public representatives. I'm specifically asking this question with, with the intention of oversight. As members of the Health Portfolio Committee, we have to, one of our main criterion of our jobs is to do oversight. So I just need some clarity on that. Secondly, yes, we know that South Africa's country TB caucus is actually very new. What have we learned from TB caucuses elsewhere that we could implement, in South Africa? Next question is, are there any audited financial statements of the country TB caucus that is available to us now as members of parliament and to the public? Next question. Please explain the measures in place to counter the influence or abuse of party politics in execution of country TB caucus's activities. And presently, or from when it started till now, has there been any instances where the country TB caucus participated in political party gatherings for TB awareness and education? Are there any prescribed practices for documenting the activities of the country TB caucus? This will just help in for oversight measures. And lastly, where does the TB caucus get funding from? Please provide a report on management and measures that are put in place to safeguard the donations, received from any form of corruption. Thank you, Chair.
Honorable Chirwa.
Thank you, Chairperson. First of all, thank you very much for the presentation. I also have a few questions here. I think 2 of them have been addressed by the previous honorable member who spoke. Firstly, I'd like to find out who does the TB caucus account to, and if they get any funding from Parliament or Treasury. If so, under what circumstances? And to this effect, how much money has the caucus gotten from Parliament and or Treasury since the establishment of the caucus? And number 2, what is the relationship of the caucus to the SAMRC? And for the research that's being conducted by the caucus, where can we access the documentation to this effect? Number 3, please explain the measures in place to counter the influence or abuse of party politics. And in this particular question, I want to drive the question to ask if the caucus has been involved or participated in a political party gathering for TB awareness and education. And if so, can you please just let us know which political party this is, and what kind of program it was held at this political party's gathering or event? And just as according to the TB caucus, then how do they deal with issues of infiltration and bias or political party bias in this regard? And number 5, what kind of relationships does the TB Caucus have with ground activists and NGOs which have been doing the work of TB prevention, education and support? And where are these NGOs based, and what kind of work have you done with NGOs and ground activists for the purpose of the programs regarding TB? Number 6, what are the systems in place in the TB Caucus that are meant to prevent corruption, to flag any form of corruption, and subsequently, what is then the policy on responding to corruption done by the personnel of the TB Caucus, and if there's been instances of corruption to date since the establishment of the TB Caucus, even if it is under investigation? And number 7, what programs is the caucus involved in relation to the vulnerable group of minors, in this case, in provinces like Mpumalanga, in regards to support, education and prevention, and general activism surrounding the issues that minors have, with compensation, with exposure to TB and all of that? What kind of work has the caucus been involved in relation to mining and minors in particular? Thank you so much, Chairperson.
Honorable Sokhacha.
Thank you very much, Honorable Chairperson. Let me also take this opportunity and thank the TB Caucus for the presentation. Just 3 questions, Chair. The first question is around the indicators. The presenter indicated that only there are about 4 indicators that could not be met, which is about close to 6%. To me, it's a huge number of indicators that could not be met. I'm sure the presenter will explain why they could not met the 4 indicators. The second one, Chair, is around the role of local municipalities. The presenter clearly indicated that there is a role for provincial legislatures. There is also a role for national parliament, but there was no clear indication about the role of local municipalities. The third one, the Honorable Shira did touch, is the issue of the mines. I just wanted to check what programs does the TB Caucus have on the mines, because according to my knowledge, the mines it's a place where the TB is most prevalent in mines. Is there any program that the TB Caucus is having on the mines? Thank you very much, Chairperson.
Yes, on my side, thank you. Mr. Coceka, can you show us that slide where you're having those 6 indicators that you say you did not meet? Because I would like to start on that one. I think you're a bit hard on yourself if you have all those indicators marked red. I agree with you. I agree with you on the go up very early. I think the second from the start. This one, yes. Where you wanted to have TB diagnosis and treatment, you were targeting to do 221,600, and you did 167 for 31. That is definitely a red, because you probably met so little compared to what you did. But why would you be looking into preventative therapy for under 5 years? You target to really get 23,900 and you manage to do 22,000, and you don't give that an aim, but you give it a red. It might actually affect those who are going to work on these indicators. I will have to put more effort on TB diagnosis and treatment than to put on preventative therapy for under 5. That was really well done. It was well taken care of. In as much as the MDR TB diagnosis and treatment, you were targeting to do 10,000 and you managed to do 8,800. To me, that would probably be an amber than to be a red. so that I could put more effort on those that are definitely red and put a little bit less effort on those that I almost achieved and did not achieve at all. So I think that slide might just be misleading if it also all of them are really marked at that level. Okay, then we can move out of that process. We can remove that slide now, thanks. Honorable members, I have known this program from the other side before I was a member of Parliament. I've always been amazed seeing an uptake and an interest of members of Parliament of other countries. I could mention Uganda, I could mention Tanzania, and some of the countries, both in HIV and TB. And I have not been seeing a corresponding interest in the availability of our members of Parliament. Because a global TB is us as parliamentarians holding the governments accountable and become advocates of TB in villages where we come from and say, government, I haven't seen you this side. Why are you not here? I've seen people this side who are suffering, but they are not accessing clinics. I've seen clinics where there's not enough TB treatment, this, that, and so in other countries, that watchdog of members of Parliament was, why do we worry? TB is very common in this country. Therefore, you worry about common things that are happening commonly. So if we could find a space to add our voice on these very common things that are happening, it will really be of great assistance. Ms. Kokega, you left me a bit confused because I would have wanted you to define what is a TB burden district, what is its figures, because the World Health Organization has got a particular figure that it uses to be able to define why do you say eThekwini has a high burden of disease of TB compared to Herigwala or Da'a. What figures, what is the quantity that you are looking into? Because it will be important because that is a measure which I think is there available. Are you able or available to share that with us? And last, you are therefore charging us to play a particular critical role, and I'm getting a sort of an indication from members here that some of those things that we are expected to play a role on, they are willing to take on. It might be a bit of we need to accelerate, honorable members. Already a particular province has launched its TB Caucus. We at the national have not managed to, not out of effort of our own, but maybe even during this time of virtual platforms, let us maybe indicate our availability. But members have also in the start of this meeting indicated that they would like to do other things for the next 5 weeks and not be available for some of this work. So it probably may be something that might have to delay a bit until honorable members are available to handle some of these programs. Back to you, Mr. and your team.
Thank you very much, Chair. We will try and respond to some of the questions that the members have put forward. I think let me start with the question around the link between the provincial district AIDS councils and the TB Caucus. I think, Chair, you touched a bit on responding to that question, because the AIDS councils are coordinating the HIV, TB and response from the government side. So we've got our MECs sitting in the PCA to be able to respond what their departments are doing and working multi-sectorally with civil society as well with the private sector. But then the TB Caucus is then placed at the legislature, looking at members of the legislature and looking at members of parliament, and not necessarily looking at the members of the executive committee that are deployed to government departments. So this is work that is supposed to be done by the political leaderships in their capacity as politicians and working with their constituencies and their communities to be able to drive the awareness of TB in the community, as well as the chair had articulated, hold different government departments accountable in the work that they need to do around the TB, and also as legislatures be able to drive legislation and policies around TB in the country. Currently, we are funded by the Global Fund as SANAC Secretariat stroke TB Caucus Secretariat. The Global Fund had given us an amount of 11 million rands over 3 years to be able to support the work of the TB Caucus. So from this money, we are able then to be having a TB Caucus Secretariat person that is responsible for driving the work around supporting the TB Caucus work. The work that we're doing in terms of supporting the launch of the national as well as provincial TB caucuses will be coming from that budget, and also the work, the awareness work, that is the information and communication work that we will be doing with the members, making sure that members are able to talk on the radio, making sure that members are able to be writing pieces of information that is going to go out either electronically in social media spaces as well as in media. That is the work that will be supported from this budget. From Treasury and from Parliament, we have not allocated any budgets for TB Caucus. As the chair had indicated, the first TB Caucus was launched in 2018, just towards the end of the 5th administration of government. And as we were starting with the 6th administration of government, we got our work. So we haven't done a lot of work around TB Caucus for us to go back to Treasury and request some funding to do this work. So probably that is the work that Chair can guide us as we go forward with the work, and we have tangible activities for the TB Caucus. Then we can be working with Treasury to see how much budget this can be allocated to support the TB Caucus work. Where the member asked a question around about what about local municipalities. We had thought that in this 2 years, which was 2020, 2021, we would start by making sure that the TB Caucus is functional at a national level and at a provincial level. And then we will then go ahead and work with the municipalities. But provinces like Mpumalanga, already they have coordinated their speakers forum, which includes the district municipality speakers, and we've already presented to the district municipality speakers on the TB Caucus. So other provinces are already engaging at district level, and other provinces have not. So Chair, our plan is that for our work plan for the next year, we will also start engaging with district municipalities, because that's where services are implemented. Members asked about engaging in political gatherings. To date, we have not been invited by any political party to support a political gathering in ensuring that there will be TB messaging and TB services at a political gathering. But naturally, when members invite the TB services support within the party functions, we will then be working with the Department of Health as well as NGOs that provide services in the communities to make sure that in that gathering, there will be activities around TB messaging. We will be doing screening for TB, as well as ensuring that those that are found positive are then linked to health services. So that will be the nature of the activities that could be implemented in political gathering around supporting the TB response in the country. But to date, we have not participated in any gathering. Chair, there was a question around lessons learned from other countries. So countries that have had made progress, especially in the region around TB Caucus, we've seen members of parliament being vocal in ensuring that most government departments that have a key role to play in TB, for example, your Department of Transport needs to make sure that there is proper communication and awareness around infection control and ventilation in public transports. The Department of Housing is critical in the types of housing that they are building to ensure that they adhere to TB ventilation in the structures they're building, the Department of Basic Education, to make sure that within the classrooms, learners are aware of infection control, ventilation, as well as screening of learners when they get into the education sector. The Department of Labor, members were asking about mining as well as construction as key industries that drive TB infections for men. So those are the different departments that we need on board to be able to drive the agenda around TB prevention, so that the Department of Health, in the work that they are doing, they can be able to meet the indicators, as you've indicated, Chair, that we are able to screen at all levels in the workplace, in the schools, in transport. So the TB caucus in other countries have already started work in ensuring that as legislators sitting in the legislature, when people are coming to present, departments are coming to present their work within their core mandate, they need to also to make sure that they mainstream TB in the work that they are doing. So the members in other countries, that's the work that they've done. Also in political gatherings, in constituency gatherings, members will also be making sure that they are able to articulate what drives TB infections, what measures can community take to protect themselves around TB, what are the signs and symptoms of TB, and when you see those signs and symptoms as a community member, what are the next steps that you take? So that's the work that members are doing in other countries to make sure that their constituencies, their communities are protected around the TB work. In terms of oversight for the TB caucus chair, I'm hoping that you will be guiding us in that work. But as we had indicated, the work of the TB caucus is the advocacy and activism of the members to ensure that there is visible political leadership around the response for TB. And the two chairs of the chairperson of the Portfolio Committee for Health and the NCOP are co-chairing the TB caucus. So I think it will follow the same route of accountability with the other activities that members in these portfolio committees get engaged. But I think, Chair, you will guide us on how best we can ensure that we are able to make sure that there is oversight for the members. The member asked what are the key activities. So as I've indicated, members in the workshop that we'll be having with the members, we will give members information and share some of the activities that you can undertake. We will also share with the members so that we can be able to confidently talk about TB as a disease and how TB affects our communities, the socioeconomic status of the country, but also members will also be sharing information on TB stigma so that we can also be able to talk and address issues around stigma and discrimination for communities that are affected with TB. So we are hoping that after we've had this workshop and members have the information that they require, and we would share some of the materials that the members can also use when they are engaging, then members will continue to call and talk about TB. One of the challenges that we have, Chair, in South Africa is that for the whole year we keep quiet and not talk about TB, and we only talk about TB in the month of March when the world is commemorating TB. So the TB caucus work, members will ensure that there will be continuous conversation, dialogue around TB, and we continue to raise the flag around the challenges that we have as a country with TB. The Deputy President, in his capacity as a chair of SANAC, this morning in Ehlanzeni, where the TB Day commemoration is held, accepted a memorandum from the TAC, the Treatment Action Campaign members, that marched to hand over this memorandum, where they were requesting the DP to declare TB as a crisis in South Africa. So that is the work that we will also be addressing and contributing to, that as members of Parliament, we will be leading those conversations to say, now that TB is a crisis in South Africa, how best do we respond as a country? And the members will be then showing that political leadership and that political activism around ensuring that TB remains a key priority in the country. The other question that we had was around the current NGOs that are implementing and supporting work in South Africa, as well as work that is happening around minors on TB prevention. I'm going to ask Mr. Tlachwako to take those questions. Sibusiso?
Mr. Tlachwako.
Sibusiso?
Hi.
Yes.
Hi, and Parliament. Sorry for the background in terms of where I am. I'll start with what MPs can do, and just to reiterate the fact that the Caucus initiative is an apolitical initiative, and basically then it means all members of parliament, all parties are part of it, and there is no favoritism in terms of whom we interact with. And then I'll also add in terms of what MPs can do. We've already mentioned the workshop. That is one area that MPs can support, and then that is the capacity building, and then it's the op-eds. We would love to work with all members of parliament, particularly the leaders of the different parties, in terms of writing of the op-eds, as we've done with Honorable Domo, and also as we've done with the Northwest. And then we're also hoping to have an induction, or also hoping to have a presentation to the Speakers Forum. I think those are some of the activities, and then we're also looking to work with Parliament in terms of the debates. So in terms of our work with the mines, our approach is mainly focused on working with politicians, with legislatures at national level and at provincial level. So until we have a work plan that will clearly identify or help us identify where we can work with miners, and the mines and TB, it's a big problem, and I think Honorable Doma did mention that at the beginning. So if there is political voices that we can work with yourselves to lend towards mines taking more accountability in their TB response, I think that is something that the Caucus Secretariat can do. Thank you.
Are you done, Kotseka?
Yes, I'm done, Chair. On the question that you have asked us around the numbers, I'll be sharing with you that slide where we are looking at districts that have highest a burden of TB in terms of numbers, and aligning that with the WHO criteria. So we've got that, and we'll share with Chair in a slide when we share the presentation. And Chair, we also note your comment around the targets that we've reached and we have not reached. So we'll also correct that slide before we can share with the members this presentation. Thank you, Chair.
Honorable members, it's very encouraging, the questions that you have posed, showing your interest on this process. I just wanted to request that we take it up even much more. It is us as honorable members who can be able to say, because I mean, we don't want to get into the turf of other members who are working with us, but we could actually volunteer to work with members who are assigned to, I don't know what portfolio is that, of correctional services, to visit prisons, just to check what are the programs that are focusing on treating prisoners on TB there, because if you don't treat them well, whether it's a responsible correctional service or the Department of Health, we would come to hear that story there. But if you don't treat them well, they come out of prison with TB and an infect. Again, Honorable Chirwa, issues of minors, we could be the portfolio committee working with them, portfolio committee on minerals and what have you, to visit Chamber of Mines and get to speak to the owners of these miners. What are you doing about TB programs in your TAF? How well do you look after people who contract TB? So that we could also be, I'm sure we could say that's a duty of the Department of Health, but we too should then be able to be able to hold some other stakeholders accountable if they have TB, because we are saying TB is so common. You find it in prisons, you find it in villages, you find it in schools, you find it everywhere. So we are all over there ourselves. So we may also add on to create our programs that can beef up this process. So I'm encouraged by some of your comments that we are going to probably be able to work out a plan amongst ourselves. When do we probably put a debate in Parliament on this process? When do we officially launch ourselves as a TB caucus? And when do we then start engaging, going around, actually advocating for TB treatment and prevention in the societies? We thank this team that has provided this insight to us, and it does look like our members are highly motivated to take up this additional contribution from us. Any last word from you, Ms. Tokeka, or the team that you work with?
Chair, would like to thank the House for giving us this opportunity to come and present. And as you've indicated, this is a very historical day, because currently, as we present here, the World TB Day commemoration event is taking place in Ehlanzeni. So I think the Portfolio Committee on Health is on it with TB, that on this important day, we will also be having TB conversations with the Portfolio Committee. So we're looking forward to hearing back from the Portfolio Committee on the proposed activities that we had tabled, and we look forward to supporting the committee with the work that it will be undertaking to contribute to eradicating TB in the country. Thank you, Chair.
Thank you very much to the team. You are then released with just a few other things to sort out. We thank you. We'll keep in touch with yourself. Thanks.
Thank you, Chair, and good afternoon.
Thank you.
Yeah. Honorable members, with your permission, I will then be writing either to the chair of chairs or to the speaker, requesting that this program be fast-tracked when we come back. So if you do give me that permission, we'll write that we have had this presentation that has actually motivated us to play our key role, because as parliamentarians, we are the ones who are targeted to play a leading role. I will also speak to the co-chair in the NCOP, because I would imagine it would probably a debate in process, but then I will then communicate with you their responses if you so support. Thank you very much. Ms. Machalamba, the next item is minutes of last week. Can you have them flighted, please? Okay. All right. This was a briefing by SAPRA that came to brief. Yeah, this was a briefing we had from SAPRA, and the briefing was on ivermectin and vaccines. Just note, go down, check, honorable members, if your number is there on the right slot and spelled correctly. Yes. Is Ms. Chirwa NN now, or MN? Is this correct now? NN. Okay. Move down. Any honorable member who, after reading the minutes, would like to add an amendment, a correction on the minutes? None. So we would like to say the minutes up to page 7 are a correct reflection of our discussion. Let me just see the last paragraph is okay, summary of responses. Go further down. Yes. Now, on that point number 4, he further informed the members that the committee will consider having meetings during the constituency period to receive updates from. This one I'll communicate with the members because we are in a constituency period now, and therefore members have indicated their unwillingness to be able to get any work done. I would imagine that will include that those fortnightly briefings that we wanted to have with the minister will also fall off until we reconvene after the 3rd of May. And if members are saying that, then let's get that confirmed in the minutes. In our discussion page. Can we adopt these minutes as a true reflection of our discussion last week? Honorable members. Any member who would like to move for the adoption of these minutes?
I move, Chair.
Chairperson.
Honorable Dr. Jacobs moves for the adoption. Honorable Keller.
Yes, Chairperson. I want to second, but Chairperson, I wanted to raise the issue of us having a meeting, a briefing meeting with the minister. I think it's very important for us to have those sessions so that at least we are on board as members of parliament, especially as we know that we are still faced the COVID-19 and there are a lot of challenges and there are many things that are happening. We need to be updated, Chairperson. Then I'm happy because it's also reflecting on the minutes discussion that we had last time regarding the NHI and also the request that we have forwarded to us to consider maybe to have a 1.5 day to continue with the 121 submission because it's a lot of work that we must do as portfolio members. Although we understand that we are also faced a local government election, we must also do Chairperson.
Honorable Keller, I was allowing you, if you are seconding the minutes, let's get that over and done with first.
Okay. No, I'm seconding, Chairperson, but also saying that if portfolio members can also consider the issue that I raised of us having the meeting with the minister to get the briefing, Chairperson.
Chair, may I?
Okay. Okay. I note that despite our being on a constituency week, we will be able to engage and take the briefing from the minister. I also had my other additional requests, which was about the NHI. So that one will also keep discussing and see if it comes through, then it's fine. If what Honorable Keller is saying is supported, I think in this week we will be going through our fortnight. We agreed that the minister, if he can brief us fortnightly. So that is coming in somewhere this week. If we could then allow us to proceed with that, any member who will have a challenge if we respect our fortnightly engagements with the minister in the light of this pandemic that we still have.
Chairperson?
Honorable Ismail.
I agree that we should continue with the fortnightly week the meetings with the minister.
Okay. All right. Then that brings us to a close. Is that true, Honorable Member? Yes, that brings us to the close of our meeting today. Thank you very much for your participation right from 9 o'clock. We started logging in 9:15, right until now. Have a good afternoon and do continue to do good work wherever you are. Thank you very much. Meeting is adjourned.
Thank you.
Thank you, Chairperson.
Thank you. Thank you very much.
Thank you, Chair.
Thanks, Dr. Hubbard.